Good morning. I'd like to call the meeting of the Legislative Commission's Budget Subcommittee to order. Good morning to everyone here in the room. I'll be chairing the meeting today. Will the committee secretary please call the roll?
Assemblywoman Anderson. Assemblywoman Backus. Assemblywoman Brown May. Assemblywoman Dickman. Assemblywoman Gorlow. Assemblyman Hafen. Assemblywoman Hardigy. Here. Assemblywoman Kasama. Here. Assemblyman Miller. Present. Assemblyman O'Neill. Here. Assemblywoman Peters. Here. Assemblyman Watts.
Here.
Assemblyman Yeager. Here. Senator Canizaro. Here. Senator Goycochea.
Here.
Senator Harris.
Here.
Senator Neal. Here. Senator Nguyen. Here. Senator Severs Gansert. Here. Senator Titus. Here. Vice Chair Monroe Marino.
Here.
Chair Dondero Loop.
Here. Thank you very much, and please mark Assemblyman Hafen present when he arrives, and welcome to Assemblyman Watts, who is on Zoom. Before we move on with today's agenda, I'd like to remind all the committee members and members of the public to turn off or mute any of your electronic devices. And for those of you who will be providing testimony today, please remember to state your name for the record each time before begin speaking. And if you have a business card, please provide that to the committee secretary before leaving the committee today. So we'll move on to agenda item number 2, public comment. This is the first period of public comment. There will be another public comment period at the end of today's meeting. Due to time considerations, each person will be given 2 minutes. And please remember to state and spell your name for the record and then begin your statement. To call in to provide testimony, please call 669-900-6833. And when prompted to provide the meeting ID, please enter 854-3818-1804 and then press pound. When prompted for a participant ID, press pound. So we will begin with public comment here in Carson City. Is there anyone in Carson City who would like to give public comment? Seeing none, is there anyone in Las Vegas who would like to give public comment? Please go ahead when you're ready.
Good morning, members of the Budget Subcommittee. For the record, my name is David Doyle, D-O-Y-L-E. I'm a foster parent in Clark County for the last 20 years, proudly serving 4 juvenile justice youth and those youth residing in specialized foster care. I'm also the director of Eagle Quest, the state's largest therapeutic foster care provider, as well as our state representative for the Family Focused Treatment Association, bringing best practice to therapeutic foster care. I'm here today just in support of the governor's recommended budget as it pertains to the 25.6% increase to foster care. And I just really want to thank Governor Lombardo for supporting this, as well as the tireless efforts of Administrator Pitlock and Director Whitley to make this possible. As a foster parent myself, it's been years since foster parents have received an increase, and as you guys know, as families of your own, costs have gone up, and it's really tough, and we are in a national as well as state shortage of foster parents. So this increase, I believe, will have a profound impact on other people expressing interest to become foster parents, so that it's not a financial burden and they can care for our community's children. And what I ask everybody at the subcommittee today is, regardless of what party you're in or political affiliation, I think we all agree our most vulnerable children really need to be at the forefront and are the future of our community. And if you could please support the governor's recommendation here for the increase in foster care, we'd greatly appreciate it. Thank you so much. That concludes my public comment. Thank you.
Thank you very much, and good morning, Mr. Doyle. Thank you for joining us. Anyone else in Las Vegas? Seeing none, we'll go to the phone lines. And when you're ready, BPS, go ahead.
Thank you, Chair Dondero. If you would like to make public comment for today's meeting, please press *9 now to take your place in the queue. Once more, if you would like to offer public comment for today's meeting, please press *9 now to raise your hand and take your place in the queue. Caller 087, you are unmuted and you may begin.
Good morning, Madam Chair and Committee. For the record, my name is Caitlin Gatchalian, Caitlin, last name Gatchalian, and I'm the Government Relations Director for the American Heart Association Nevada Division. On behalf of the American Heart Association, I would like to urge the legislature to take action on extending postpartum Medicaid coverage from 60 days postpartum to 12 months. Health insurance status is one important dimension of access to care, and studies have documented disparities in health insurance coverage among low-income, young, and minority populations, as well as adverse maternal and infant outcomes among uninsured and Medicaid-covered women. Pregnancy and birth complications, as well as social determinants of health, increase risk for cardiovascular disease in women. More than 1 in 3 maternal deaths occur following birth, with cause-specific mortality from heart disease and stroke being highest in the year after giving birth. We all want babies to have the best possible start in life. Ensuring the expectant parent has access to care during and for the first year after giving birth is essential for providing a healthy and successful start. Extending Medicaid coverage from 60 days to 12 months following birth is important to addressing health issues that are discovered during pregnancy or resulting from pregnancy, and will allow lower-income pregnant women to obtain comprehensive care coverage so they can get all of the health care services they need to be healthy during and following pregnancy, better birth outcomes due to fewer costly medical complications during pregnancy, and assisting with early identification and treatment of postpartum depression, quitting smoking, preventing violence, and treating substance use disorders. Caring for women and birthing parents in their productive years while ensuring maternal health is equitable across populations begins long before pregnancy and lasts well beyond childbirth. Saving moms' lives requires a policy roadmap to better health. The American Heart Association recommends policy solutions that are sustainable and impactful for preventing maternal death and ensuring all mothers can live healthy lives before, during, and after birth by extending postpartum Medicaid coverage from 60 days to 12 months. Thank you for your consideration. I will follow up with a letter soon.
Thank you. Next caller, please.
If you have just joined us and would like to offer public comment on today's meeting, please press *9 now to take your place in the queue. Once more, that is *9 now to offer public comment for today's meeting. Thank you, Chair Dondera-Loop. The public line is open and working. However, there are no callers to offer public comment at this time.
Thank you very much. And so now we'll go on to agenda item number 3, and we'll be hearing budget presentations from the Department of Health and Human Services. First up, we have the Director's Office and Director Whitley and team. Please join us, and we look forward to hearing your presentation. Go ahead when you're ready.
Good morning, Madam Chair and committee. My name is Richard Whitley, and I serve as the Director for the Department of Health and Human Services. With me today on my right is Marla McDade-Williams, and she serves as the Deputy Administrator over Programs and Policies. And on my left is Stacy Johnson, and she serves as the Deputy over Budget. Thank you for the opportunity today to present our first of many, probably, appearances before you to present our budgets, and we're happy to be here. We've, as a department, have been through a lot and have implemented a lot, and we're looking forward to this budget sustaining and continuing making improvements. So thank you for the opportunity. If I may just begin with our slide presentation.
Please go ahead.
Slides 2 and 3 are the department's mission and organizational chart. If you go to slide 3, our department is, as you likely know, is organized in divisions, and our functional role runs the gamut from eligibility for services, funding services, regulating services, and direct delivery of services, somewhat serving as the state safety net in many areas in behavioral health and other services. So I didn't do a slide on challenges. I think you'll hear from everybody, the challenges with workforce. I've asked the administrators to specifically speak about how that impacts the programs that they provide, with direct services being the most difficult. And I think, without sort of looking at all of the workforce in specificity, it really is hard. Even just giving you an overall vacancy rate doesn't really tell the true story for our department. And so you'll hear from each division how they are directly impacted, and especially those that do try to provide direct services. And where it's most crucial then within there is in our facilities. I'm very proud to say that all of our hospitals and treatment facilities have not only continued to provide services, sometimes not to the community need, but we have maintained our Joint Commission accreditation and certification through the process. So it's a balance of meeting the community needs and ensuring that we protect people and provide quality services. So I just give that as an overview, but you'll hear more specifics from each of the divisions. Turning to page 4, just jumping into the department priorities in a more of an overview. I really looked for the themes that I think that you'll see in our budget. And, in a budget presentation, you don't really get, because it's all categorical, so you don't really get to see the total impact. But provider rates, it's a huge, it's probably unprecedented, at least in my tenure as director and as a division administrator, to have this number of categorical rate increases for providers. Usually it's a struggle between which industry gets the provider rate increase, and I'm very pleased that we were able to look in total at the impact. I think again, you won't see this captured in the categorical funding, but in Medicaid's budget, I think the heavy lift that will be achieved is really a focus on primary care, helping to prevent hospitalization and crisis by actually investing in nurse practitioners and services that can occur, in a physician's office. So again, not captured in the categorical budgets, but definitely a theme here, provider rates, probably our biggest one, that will have the biggest lasting impact on service systems. As some of you know, during IFC, we came forward nearly every IFC, it seems like, with relief fund requests to stand up services. It's one thing to stand up services, but to actually be able to implement them and sustain them, the rate really is going to be transformational across the board in terms of this investment. As I touched on, though, there are some themes. Behavioral health, certainly, I think a lot of improvements have been made, but a lot of work still to be done. That's that upstream approach, both with children and adults, where we could prevent when someone needs to be hospitalized, they need to be hospitalized and hospitalized in our state. But if it could be prevented, there's an obligation to go upstream and to prevent those services, in the least restrictive environment. So you'll see that here as well. And then a criminal justice piece, same concept. If we could intervene early and prevent people from being incarcerated, we really should there, and getting them seen. So I'm very proud of the items related to behavioral health for just continuing to make improvements. This didn't get much attention, but the national rankings for states came out late October, early November. But Nevada moved to a ranking of 29. We have traditionally been the worst in the nation. And so we have made some improvements. It's hard when there's unmet need, though, to pause and say, we've had a success. So, and if you're a consumer, it doesn't feel like a success if you have an unmet need. The final area I think that is captured in our budgets is I called child welfare, not in the child welfare traditional way, but in the welfare of children. From prenatal care, if we can launch healthy babies, they're off to a good start. You'll see that in the budget as a request. About 55% of the births in our state are paid for with Medicaid. So I think it's a state intervention with a population that we cover those lives, getting them into prenatal care and having those births be healthy births is a priority. And then early intervention and services along the way to keep children healthy, that's a part of this as well. So you'll hear that throughout different divisions, and I just thought it warranted pulling out. And in our subcommittee, I'll probably do a better job at just focusing on some of the other populations that truly do benefit out of this, because I think it's worth saying. And then it's the burden is on us to then work with the provider network to make it easy for them to be a provider of our services. So I have to stay on track with my with my presentation. So turning then to slide 5, this shows the department's budget by funding sources. So federal funds represent about 55% of the overall governor's recommended budget. General fund request is 20% of the total budget, and other makes up about 25%, and that includes fees and some of the settlement funds like tobacco and opioid. The most significant change is found in the federal funds and other funds, and that's primarily due to caseload growth, inflation, and the provider rate increases I mentioned. Moving to slide 6. This chart shows the general fund by division. General fund request for the upcoming biennium is about $4 billion, and it reflects growth of about $693 million, or 21% from the previous biennium. The largest growth would obviously be in Medicaid, followed by aging and disability services. And the primary reason for this increase in general fund is related to the federal medical assistance percentage, or FMAP. And so as that, with the public health emergency going away and the FMAP changing, the burden on state general fund increases. And that's probably the largest reason for the increase in the general fund request. Then that's really it for my high-level overview for the budget for the department. I'll move in now to the budgets that I directly have in my office, which don't compare to the divisions really in terms of as much funding or impact. So we have the role of oversight, and then we do manage some specific budgets. So turning to page 9, or slide 9. Did I skip it? Oh, I did. Thank you. So this slide is a summary of our operations and those budgets, or those programs that we oversee. Some of the impact is really, or it's managed in our office because the policy touches all the divisions, and it is just best impacted when it's able to work across the divisions. Others are funding, and it's an investment in funding across the divisions and to the community. And then others we just have found, like last session, you approved me moving all of our categorical data analytics into an office in my office to serve the entire department. And I mean, if you need only look on our website and go to the Office of Analytics, and you can see dashboards that really show. I mean, one that I'm really proud of is discharge planning with Department of Corrections, and legislation occurred last session to get the inmates leaving prison enrolled. The dashboard shows by prison inmates leaving, the denominator, and then those enrolled in prison. And, you know, it gives us an opportunity when you have that level of information to actually intervene in strategic ways. You don't have to go globally and hope that you're able to effectuate a change, but it really identifies where problems are. So we probably could do better at framing some of our data to be able to make it more useful, but it's probably incremental. The first step was pulling it together. So I'm grateful for those of you that were here last session on the support in moving that together into our office. We have haves and have-nots with data. We have grants that are primarily data, and then we have other grants that have no data but just programming. And so we've been able to really see a synergy in that office. So that's the role really of the director's office for DHHS. Turning to slide 9. This shows the budget funding for the director's office. The total revenues are about $205 million for the biennium. The general fund is only about 3%, or $6.7 million for the biennium, and approximately 40% of the general fund is really recouped through cost allocation from the divisions for the administrative services. The federal funds make up about 24% of the revenues, and then the majority of revenue is other, which, as I mentioned before, is primarily settlement funds from Fund for Healthy Nevada, or tobacco settlement, and then the opioid settlement funds. Turning to slide 10, this is the summary of the budget accounts. And I have one major highlight on slide 12 in this budget, and that's the Fund for Resilient Nevada. And it was established last session, and it's governed by statutes. It was set up similar to the tobacco settlement funds, the Fund for Healthy Nevada. It's called the Fund for Resilient Nevada, and NRS 433.738 authorizes the statewide plan to provide an allocation of funding to support certain statewide projects and services to really remediate the damage done by opioid abuse. It provides grants, or will provide grants regionally to local and tribal governments and to the private sector organizations who work in this space of providing substance abuse prevention and treatment. The statewide plan has been completed, and it is on our website. We'll be actually going to IFC next week with seeking authority to begin the work with putting out the RFP and awarding funds to community. As you might know, the settlement funds from the Attorney General's office were in reaching the settlement. Some of the funding goes directly to local government and some to the state. So it makes it important that we really coordinate with local government in terms of how we respond. So many of the services are covered by Medicaid, but there are things that aren't, beyond treatment, like returning to work or child care for your children while you're in treatment. And so we really are being deliberate in making sure that we utilize these dollars. I would in a way that fill gaps and not subsidize existing funding. You know, it's often easier to get a grant and get funding than it is to bill Medicaid. You'll hear from Medicaid, we're trying to make that easier, but it's still more challenging than a categorical grant. But you know, with scarce dollars, and it's just the right thing to do, we should help people to appropriately bill for services and use these dollars that have a margin to fill gaps that there are no other funding sources for. So really, Dr. Woodard couldn't be here today, but really she has worked tirelessly on this, not only with the AG's office and achieving the settlements that we've continued to get, and then on the planning. And so I wouldn't be able to present this if it hadn't been for the work that she's done on this. So next steps in that is get authority for use of the dollars, and then the RFP and putting them out to communities. Turning then to slide 12, this breaks out the Fund for Healthy Nevada. Again, this is the tobacco settlement funding. I would contrast that the Fund for Healthy Nevada, the tobacco settlement, that's in perpetuity. So there's a perverse dynamic here. If people smoke, the impact is to try to reduce tobacco use, but we do receive funding from the use of tobacco, and that's in contrast to the opioid settlement funds, which are not in perpetuity. They're, settlements that have occurred, and when the dollars are used up, they won't, we won't have them anymore. So just contrast those two. They're both settlements, but they are their longevity is different. On the tobacco settlement or the Fund for Healthy Nevada on slide 12. The revenue remains steady, some slight increases over the past 10 years, and it yields about $24 million for the investment in this specific program. The next slide shows how the Grants Management Advisory Committee allocates the funds. This chart shows the categories where tobacco funds are proposed to be spent and the differences from last session. And the main areas of change really are the Senior RX program, and that's primarily due to the changes with Medicare and Part D, and less of a need to actually supplement with other funding for prescription drugs. And so what you see in the budget is actually what was spent last year. And then an increase in independent living programs to address broader services for that population that benefits from these resources. And then the Office of Minority Health, it's to increase funding to cover the costs of 2 contract positions. And then the administrative funds were reduced because it's based on cost allocation, so it actually is based on what actually is provided. So that's a summary of the Fund for Healthy Nevada. Moving to slide 14. This shows the allocation of Title 20 funding. This is a block grant, and here we are projecting a slight increase in the total funding. Moving on to the next slide. This slide and the next one cover 2 programs that are pass-through funds to the Division of Healthcare Finance and Policy, or Medicaid, for supplemental payments to hospitals. Because the rates paid by Medicaid are below the upper payment limit, which is the Medicare rate, this program is supplemental to those reimbursements. The first program is the upper payment limit, and this is a pass-through account, as I said. The slide shows the total amount of contracts and the amounts that will be reverted. We're projecting 43 contracts and approximately $11 million each year. The budget includes transfers to Medicaid of about $8 million. per year, and reversions of about $3 million. The federal match, which is really the benefit of this program, is that it allows Medicaid to make approximately $21 million in supplemental payments each year. Turning to slide 16. The second program is the Indigent Hospital Care Act. This program was established to reimburse hospitals for uncompensated care. And as you know, with the Affordable Care Act and Nevada participating in the expansion of Medicaid, our uninsured rate has continued to decrease. We probably have about a 10% uninsured rate right now, or about 350 million Nevadans. So the uncompensated care has really gone down in terms of what hospitals are able to get reimbursed for. Nationally, this really hasn't been addressed by CMS in terms of how to retool this program. As a state, we're managing it, and fortunately, the way it's set up is there's a board of trustees with NACO, the Nevada Association of County Organizations, and they have authority for some decision areas to invest these dollars in. A small amount goes to NACO for the oversight, and then there's the traditional accident fund payment, and then the offset to county match, and then funding is transferred to Medicaid to be used for supplemental payments. The board voted in March of 2022 to continue to use the ad valorem property tax to offset county match and the unmet free care for supplemental payments to hospitals. That really concludes my overview presentation, and then the more detailed look at the budgets in my office, and I'm happy to answer any questions.
Thank you very much. And we'll start with Assemblyman Yeager has a question.
Thank you so much, Madam Chair, and thank you for being here, Director Whitley, and thank you to your team. This may not be a question you can answer, but I'm going to ask it because you're here. The opioid settlement funds for the Fund for Resilient Nevada, obviously in favor of the efforts that are being used to get people off of opiates. The more that I read about, the history of opioids and how they were pushed in this country, and I'm not going to single out any manufacturers, but just it's really shameful, to be honest, and I think it's why we see ourselves now transitioning to a fentanyl crisis, because we've tried to attack that problem, and I think we've done a good job, but people are still, they're still hurting, and they're still looking for other substances. So I guess here's my question. The money that you have in that fund that you've been given, are there restrictions on it? Because what I think we've missed in a lot of this is trying to compensate or provide treatment or support for family members of those who have died from the opiate crisis. And I just wondered if that's a part of this, or are your hands tied in terms of how the settlement was reached and the funds that you were given to do specific things for people who are now experiencing that crisis?
For the record, Richard Whitley, and I probably didn't do justice in my brief overview of just indicating there is a wide margin there, and the Attorney General has, in those settlements, remediation is the key, and the definition of that really is broad. And you're right, the impact on families, on children, we have a high rate of women particularly in southern Nevada, who don't access prenatal care. And some of the underlying issues are not, they themselves may not be a substance abuser, but their partner may be. Or they may be, and the child is impacted, and getting that child assessed and early intervention services. I think there's some huge opportunity there. I mentioned the child care. I mean, we can support a single mom going to treat. I've heard this story by many women where they go to treatment, they're doing the right thing, and then of course their children become primary importance to them, but they can't go continue their treatment because of their need for childcare. So there are gaps in the system, and these funds do have the latitude to address those. Unlike Medicaid, which is pretty categorical in eligibility and then service provision, that's why we want to maximize and invest those dollars where other funding sources can't be spent. There's even the benefit of these dollars that the AG allows us, that if we did see a Medicaid service, we could use, and CMS allows this, for the opioid dollars to be used as the match. And honestly, I could be criticized probably for not moving faster in getting these dollars out. One is, I think we really wanted to be deliberate, but the other thing is not knowing where the economies was going to go. Just wanted to make sure that we didn't squander that opportunity if we did need to rely on these dollars for the state match for Medicaid for some of the crucial services. So sorry, that was a long answer, but yes, it's a broad use.
Thank you very much. Assemblywoman Gorlow.
Thank you, Chair, and thank you for being here. I wanted to touch base on the tobacco settlement with the cessation budget. Even though there's an increase of almost $2,900, it's pretty much a flat. And I'm hearing that there is an increase, especially in our teens with vaping products specifically, that they are increasing usage. So can you elaborate just a little bit on what that program looks like, how we're targeting some of our more vulnerable teens, and also what is the CDC recommended amount for that funding?
For the record, Richard Whitley, through you, Madam Chair. I actually think a report from the Lung Association came out yesterday and has grades for state. We're not the worst. We're not amongst the bottom, but we did get an F. We got 2 C's in 2 areas, so that brought us up. And they really do break out. And I don't want to misspeak, but it does. If you look at that National Lung Association report, it does show what CDC recommends. That's one of the scoring elements. When it comes to cessation, this is one of those areas where, again, relying on the funding sources that are available. In the Affordable Care Act, there is a preventive health package, and it does include tobacco cessation. So, primary prevention should be something that these flexible dollars can address, but cessation is a covered benefit as required by the Affordable Care Act. And so, like a lot of things, we saw this in HIV 20 years ago when when a funding source gets established formally, you have nonprofits sometimes that don't operate in that space. And my hope with Medicaid is that we could get more providers enrolled and really demystify the billing so that we could reimburse and then utilize these dollars in the flexible ways they're available. Similar to the narrative I was explaining with opioids, probably have the opportunity to get that right from the beginning. But cessation is reimbursable, and the investment that I'm not negating that the dollar amount we invest in tobacco prevention is low compared to other states. Again, you can see that in that national report card.
Thank you so much.
Thank you very much. Assemblyman Hafen.
Thank you, Madam Chair, and thank you guys for being here today. I do have a number of questions, but just kind of starting out, the opioid, I believe the speaker mentioned people are gone to fentanyl now. What other drugs are we using those settlement funds where you mentioned other substances?
For the record, Richard Whitley, Madam Chair, through you to Assemblyman Hafen, we haven't used them yet. we just are standing up the program. But the settlement agreement from the AG is broad to substance abuse, not just specific to opioid. But again, in that same logic of does this service already exist and is it covered somewhere else? We would look at the substances being used and what's emerging. I mean, that's the other benefit of these dollars, I think, is the flexibility. I mean, I perhaps don't have to wait 2 years to bring before you that something is happening now, that the authority to spend those dollars on that broad array of substances is available in that funding through the settlement. So it is broad.
And I don't expect you to have this with you, but you mentioned the discrepancy between Medicaid and Medicare. Could you provide us with the surrounding states and the differences between what Nevada is reimbursing for Medicaid versus what, Utah, California, Arizona, et cetera? I know you guys have provided that to us in the past, and so if you could just, I have a feeling that'll be very helpful for us during the session. So if you could just provide that going forward, I'd really appreciate it. Thank you. And thank you, Madam Chair.
Thank you very much. And we'll go to Senator Neal.
Thank you, Madam Chair. So I wanted to ask a question about the behavioral health piece. So what I've been noticing when individuals, because you have this program where you're interacting with the jails, but what is happening when a bipolar person is being picked up, and like how are we managing that? Because what I'm noticing is that typically a person is maybe having a bipolar episode, probably needs to get medicated, but then there's also a conversation that probably needs to happen with their guardian as well. If they're underaged, or if they're, I've even seen it like in my district, I would say it could be a 30-year-old man, but he has a guardian or his mom or someone who's managing them, but then they end up in jail. But there's no way to try to figure out, okay, how do we get them out, get them medicated, and then bring them back home, right? Because it's not really a criminal episode, it's a medical episode that's happening on the street. Are you guys engaged in that?
For the record, Richard Whitley, Madam Chair, through you to the Senator, I would, when I gave that example of the jail and that we're looking at enrollment, the next step to that is, did they get care? Where did they get care? Maybe there are providers out there who do a great job, and we need to know that. Maybe there's a managed care. I mean, we started. We really made improvements in Medicaid with managed care, with pay for performance, and I think the next phase of that is to look at like some really hard to serve populations that maybe move through systems. How well do they do with that? So the next phase of that is to actually do a warm handoff to a service. I mean, the whole goal of that enrollment was if they get medicated, and even worse, if they're stabilized while they're in jail or the Department of Corrections, that they don't even get enough medication to last them until they can get an appointment in the community. So there's more work to be done in that area. I don't have a single solution to it. And in the jails, like here in Carson City, we have a social worker from our outpatient clinic that actually works in the jail. But that was because the sheriff was interested in doing that. Clark County Detention Center, the first jail that let our eligibility workers go in and actually in real time enroll people before they leave. So some of that is relationship in the jail. We made what I was sort of complimenting the legislation on last session was the Department of Corrections, but it really is the starting point. They're eligible for Medicaid, they're stabilized, then get them handed off, a warm handoff into service. So there's more work to be done in that area. So there isn't a program that I could refer you to other than to say I agree that there are people that need more assistance when they leave, especially if they've been made, helped to be stabilized while they were there or started on medication while they're there. And then how do we prevent it? That was the benefit that some of our local jails have seen is, and honestly, sometimes with more direct request for support than corrections, because they know that their law enforcement on the street are going to have to turn around and see this person again on the street if they're not stabilized. So it is our intention to do more in that space, to be able to and then to measure it so that we can quantify it and actually make improvements.
Just quick follow-up, Madam Chair.
Go ahead, please.
So the thing that I was considering and wondering, because I kind of sent an email before in the interim, is whether or not there's an ability to expand the street teams to try to engage in this work. I know that I don't know how much coordination is happening between the City of Las Vegas street team that they have on the corridor that only focuses on a very small geographic area, and then the street team that we're funding at the state level to try to figure out how to engage in those high zip codes where we're seeing more presence of these kinds of episodes, so that the prevention is happening on the street team side before they're taken to the jail, right? And so they're taken to a different facility, maybe it's UMC, maybe it's somewhere else, in order to manage it. And that's what I was trying to consider or think about. I just wanted to say that. Thank you, Madam Chair.
Thank you very much. Assemblywoman Hadagi.
Thank you, Madam Chair, and I have a couple of questions if I can. As I was going through the executive budget and some of our backup documents, I noticed that there was a closure of the Northern Nevada Psychiatric Residential Treatment Center at the Northern Nevada Child and Adolescent Services Campus. And if that's closed and all of those services and positions are moved to the Southern Nevada campus, what kind of access to treatment will Northern Nevada residents have?
For the record, Richard Whitley, Madam Chair, through you to the Assemblywoman. I would defer that to when the Division of Child and Family presents, but I would just say globally, in my opening statement about the workforce challenges, we can't provide substandard care in a facility type if we can't staff it. So we have had to concentrate our staff in some areas. I'm hopeful with the governor's initiative. I mean, it isn't all about salary either. And some of it is about just our timeliness to offer jobs with, believe it or not, some people do want to work for state government. And so I'm hopeful that we could make some changes, but that really is a staffing issue. And you'll hear more about that from Dr. Pitlock with the Division of Child and Family Services.
Okay, thank you. And these questions might be better reserved for another presentation as well, but I also noticed that you guys were eliminating vacant positions because caseload reductions at the Northern Nevada Adult Mental Health Services and also the Caliente Youth Center. Is that normal? Do you see that trend happening across other services where just caseloads are being reduced? It seems odd coming out of a pandemic that it's going down instead of going up.
For the record, Richard Whitley, Madam Chair, through you to the Assemblywoman. Two different divisions for that. Northern Nevada Adult Mental Health would be DPBH, and then with Caliente Youth Center, DCFS, and two very different reasons maybe for the same strategy of reduction. We have a really hard time getting staff in Caliente, congregating the female population in an area where we can get them. I mean, we can't just not provide services when we have clients we've taken on the responsibility for. And so where we can locate them to have a workforce that can provide the clinical services, I feel an obligation to do. And then on Nevada Adult Mental Health, Lisa Sherrick will present more on that. But I do think we still are seeing, as it relates to the Affordable Care Act and expanded Medicaid, and this is a good thing, that providers are stepping up and providing these services. Consumers have a choice. And so, that Northern Nevada Adult Mental Health is on a historical psychiatric facility compound. And if you have ever taken a tour of it, you can see that over the history during the last century, we have old buildings that represented hospitalization or facility incarceration over time. That's where we provide the services. And frankly, some consumers prefer to go to the private sector. So I think different reasons for different programs, but you might see a similar kind of reduction in state workforce. And so good question and better answered with specificity from the two divisions.
Thank you. And I think my concern was, as I was reading through the backup documentation, it had said that caseloads had been reduced year over year, and that's why the elimination of the vacant positions. And I just want to make sure that we're not putting ourselves in a position where if caseloads go up, then we are understaffed to handle that caseloads if they increase. And then, Madam Chair, just one last question, if I can.
Okay, quickly.
Okay, and then my other concern was I saw that there was elimination of some services being offered. There was elimination funding for neurotherapy and biofeedback services due to services as a treatment for behavioral health disorders due to improper billing. Why wouldn't we just fix the issue instead of eliminating the services? And could you talk to me about what kind of services are actually being eliminated, what that means?
For the record, Richard Whitley, Madam Chair, through you to the Assemblywoman. Again, best addressed when Medicaid provides their budget overview. But I would say that that is a service that is provided. Commercial insurance doesn't cover that service. And some of the inappropriate billing or the inappropriate billing and service, I would say, that we identified is some people with serious mental illness were only getting that service. They weren't getting other complementary services that you would think somebody with a diagnosis should be receiving. But it is a service that isn't standardized. And those of you that have been around for a long time, we had the same thing happen with basic skills, which really is a service in Medicaid that, 10 years ago, that people found a way to bill for and exploit, frankly. The consumer, who that's all they got was basic skills. So when Stacey Weeks presents the Medicaid budget, she can provide more detail on just that service. And and to your previous question too, I think it's important to put it in the context of everything else. So even the elimination of a service, it doesn't mean the service doesn't exist. It just means that the state agency isn't providing it. And how our budgets are billed and how our caseload is calculated, it would come across like that service has gone away for the consumer. But in fact, the consumer made a choice to see somebody in the community, which personally I think is a good thing, that consumers have choice where, again, a decade or 20 years ago, they only had the state program to go to. So I think we could probably do a better job at putting some of these things in context, either giving the denominator of what's available, and then on this elimination of this specific service, putting more narrative around, what like those who get that service, what else have they gotten? Because it's pretty revealing, I think, that we're not helping people if that's all they're getting.
Thank you, Director Whitley.
Thank you very much. And we'll go to Senator Gansert.
Thank you, Madam Chair. I had a couple of questions. First was about, so thank you for your work. It's a very difficult budget in Health and Human Services, just everything. It's extremely complex. So I wanted to follow up on Speaker Yeager's comments about the money from the opioid settlement. Assemblywoman Tolles and some other folks passed some legislation to create an interim working group. Senator Donate and I are on that working group, and actually the question as to whether any money can go to victims or the families, because they end up in, if they lose a loved one, they're in counseling and they've spent a lot of money trying to help their loved one, and then the aftermath of the effect of opioid deaths. And Attorney General Ford has has stated that that type of money, that those funds are not available for those types of services. And so I just wanted to confirm, and maybe it's part of how the working group was created, that it limits what we can talk about versus how those funds can be used. So I just wanted to get some information from you as far as whether that is, if it can be used for victims' families and so forth.
For the record, Richard Whitley, Madam Chair, through you to Senator Gansard. I would say my briefing with the Deputy Attorney General that was overseeing this broadly laid out what the funding could be used for to remediate. I think cash assistance isn't something, and it's not something that we actually are even equipped to manage. So I would say no to that. Like if somebody was harmed and we're giving them money for their, I mean, that isn't the purpose of the settlement. But to be able to serve children or others in the family that have been impacted by substance abuse, my understanding is yes, from my briefing with the Attorney General, that now we've put a framework around this to prioritize where the funding needs to go as a starting point. But I think the flexibility is there to remediate the damage done by substance abuse.
Thank you. So it's
Opioid.
more around services to family, not cash. And I don't know that people were expecting cash, but services to family to make sure that they've got access to counseling and whatever else they may need. So that makes sense. So thank you for that. And then I wanted to skip to the rate change for applied behavior analysis services. There's a decrease in the rate change, it says, to the average, the medium comparable states. So and it's 1.6 million in general fund, so 4.1 million after it's matched. And so what type of percentage decrease is that?
For the record, Richard Whitley, here's one where I'm clearly going to need to defer you to the division when they present to give that background.
That's fine.
If
That's fine.
okay.
I just picked that up. Just as a note, we changed, we added a behavioral health board, and we went from about 40 registered behavior technologists, the RBTs, the folks who work with the kids, in 2017 to about 2,000 now, and part of that was because of the rate increase. That was part of the driver, really. So I'll appreciate getting some more detail on that. Thank you.
Thank you very much. Assemblywoman Brown-May.
Thank you. Thank you, Madam Chair. Thank you, Director Lee. First, I'd like to say thank you for all of your really difficult work done over the course of the last biennium, in particular caring for our most vulnerable Nevadans across all sectors. I have two questions. First, on the slide 13, under the Healthy Nevada funds where tobacco monies are used, I see a decrease in the 211 supports, and I'm curious to know if you've talked about your dashboards and the data collection that we have, the utilization of the 211 hotline, is it decreasing? That coincides with the decrease in funding. What's the utilization and success rate of 211? And then I see suicide prevention. Is that the 988 hotline? Is that in there? Does that correspond? Is there funding relative to that? Can you talk a little bit about those two hotlines and how they work?
For the record, Richard Whitley, Madam Chair, through you to the Assemblywoman. First with the, 211. No, it doesn't relate in terms of, it doesn't suggest there's a reduction in volume. It's a diversity of funding sources also. You'll hear about that. Like one of the benefits, again, that the legislature allowed me to do, that was moved out of my office to Aging and Disability Services to really be embedded with other consumer assistance. And I think the program has really soared under, being placed in the proximity of other services that really try to intervene early with consumers, so it would not suggest a reduction in the actual utilization of that program.
Thank you for that detail. And then just one last question. In your presentation, you noted the FMAP increases are about to change. I'm curious to know, do we know if the FMAP decreases are going to happen all at once with the emergency ending, or is it an incremental decrease that we can see over the biennium?
For the record, Richard Whitley, Madam Chair, through you to the Assemblywoman, you'll hear more each FMAP, like the FMAP for different populations, it's complex, but you'll hear that in Medicaid's budget, detail on the impact and what that has on general fund needed to match.
Thank you very much. And we'll close this with Assemblywoman Kasama, and then we'll move on to the next presentation.
Thank you, Chair. Thank you, Director Whitley, for a great presentation and for your obvious concern for the people that you serve. My question has to do with slide number 10, the biennium budget account summary. And I'm just curious, from fiscal year 24 to 25, there is a fairly 2 million some decrease from federal funds. And I'm just wondering if, because I figure our population is growing, our need continues to go up, why is there such a decrease from the federal funds?
For the record, Richard Whitley, Madam Chair, through you to the Assemblywoman. I can pull that specifically, but the funding formula for block grants is established by Congress, and some are determined by population and are set. So I'd have to get the detail for you in terms of each one that we have.
Yeah, it's particularly the grants management unit. And I just want to make sure we're capturing all the grants that we can. Our population is increasing, and so any information on that would be helpful.
Sure.
Thank you.
Thank you very much. And with that, we will go to agenda item number 4. And we welcome Dr. Stacy Weeks, Administrator of the Division. And Ms. Weeks, please go ahead when you're ready.
Good morning, Madam Chair. Thank you, committee members. I'm going to pull up my slide deck real quick. All right. Good morning, Chair, committee members. My name is Stacy Weeks. I'm the Administrator at the Division of Healthcare Financing and Policy, also known as Nevada Medicaid. I have here with me today our Acting Deputy Administrator, Lynette Aaron. She's over our Fiscal Unit and Payments Unit. And I also have other members of our team in the audience here today, as well as Grant Sawyer Building. Before I get started, though, this morning, I would like to take a moment first to acknowledge someone who should be sitting here with me. Our Chief Fiscal Officer, Melissa Lawfer-Lewis, recently passed away. We wouldn't be sitting here, I think, today with this budget if it hadn't been for her hard work over the last few weeks. And she's definitely going to be missed. And I just wanted to note and express my gratitude on behalf of our team for her public service.
And we thank you as well and
you.
recognize that loss. Thank you very much.
Thank you. So we'll go ahead and get started. So at Nevada Medicaid, our vision is pretty simple, but it's a lot of work. The vision is to really promote a healthier Nevada. Our mission is set forth, though, in statute to help us get to this vision, and part of that mission includes ensuring that our Medicaid program is provided in the most efficient manner to the state, and that includes the state budget, such as maximizing available federal funds for the state, and also promoting access to quality health care for all Nevadans, and restraining the growth of the cost of health care in the state, which we all know impacts the budget. Our priorities are listed on this slide for you all this morning. I think you've seen many of these in prior years. We are focused on promoting access to health care coverage, specifically Medicaid. We also work to increase access to primary care, preventive services, which really helps get at lowering cost over time. With a healthier population, we can reduce costs and the growth of health care. We also work to improve access to and the quality of behavioral health services. We also try and strive to ensure pregnant women, infants, and their families have the care they need for a healthy and strong start. We also work to support healthy aging for Nevadans. We also are working to develop a comprehensive strategy for the coverage and pricing of prescription drugs. As many of you know, that is a big piece of the spending in our budget. We also work hard. We added this bullet recently because it is a very important piece of our work as we try to look at sustainability and also quality. We're working really hard now to promote new value-based models of payment and care that really incentivize and reward providers as well as our health plans for better and more cost-effective care. This slide reflects our organizational chart. As you can see, we have quite a large leadership team. We have 4 deputies, they're all here today, as well as our public information officer and 2 new clinical officers. So I'm super excited to introduce them this morning to you. There's Dr. Rashonda Clemens. She is our medical director. She's a pediatrician. She just joined our team, and we are super happy to have her. And she is in the Vegas building this morning. I also have with me here today Dr. Keith Benson. He is our dental health officer, and he too is fairly new. He comes to us from corrections, so he is not he's very familiar with state government, but new to Medicaid. So we're super happy to have a full team. We also have 2 acting deputy administrators who are newer, like myself, Lynette Aaron, who I also introduced just previously, and Teresa Karsten. She is our acting deputy over our managed care program. All right. This slide attempts to try to summarize in one slide all that we do. I will say it's very hard to summarize all of our work. We have about 300 employees who work really hard every day to ensure that Medicaid coverage is provided to those who are enrolled, and then also trying to assist those providers that serve this population. And so it's a big effort, and we are, I would say, small compared to other states, but we're scrappy, right? We work hard, and we work in partnership with the Centers for Medicare and Medicaid Services, CMS, who is our federal partner to provide quality health care to eligible Nevadans. We also work in partnership with other sister divisions who you'll hear from later today. All of our sister divisions we work closely with because a lot of their services, well, anyways, they work alongside with us. Sorry, it's early. So as you can see in this visual here, it shows us all the key functions that we do at the Medicaid department. One of the key things you often hear about from providers is our development of benefits, which includes the services we cover and the rates that we provide. We also pay providers directly through our fee-for-service program for services, and we also pay managed care organizations a capitation payment to provide services and to ensure we have networks to serve a very large portion of our population. We also work to manage our budget and for the state and all the Medicaid finances that come along, and we'll look at that budget here soon, but it's about $16 billion for the next biennium. We also work to comply with state and federal law, which, often we get asked why we can't do something, and we have to explain there is a federal law component, but there are also ways sometimes to find other options. And so a lot of our work is to, while we comply with state and federal law, but still try to meet the needs of our state and our populations. We also work to handle appeals from providers and enrollees around benefits and payment. And I just wanted to note that the eligibility and enrollment in Nevada for Medicaid is conducted by our sister division, the Division of Welfare and Supportive Services, and you will hear from them later today. All right, so I just wanted to give you a quick update on some key Medicaid statistics. About 912,000 Nevadans are currently enrolled in Medicaid. That's probably a lot more than when Suzanne Bierman sat here 2 years ago. That's 1 out of every 4 Nevadans in Nevada are enrolled in Medicaid. I would also note that our population has grown a lot because of the public health emergency. During the public health emergency, we maintained a continuous enrollment approach, and that was from the federal government, so we can ensure we got enhanced federal match. And during that time, we've seen a 42% growth rate in our population that's covered. The fiscal year spending for 2022 was about $5.5 billion. And we cover in Nevada, Medicaid covers about over half the births, and that's about 19,000 births a year. We also cover, as you guys know, we have two delivery systems. We have a fee-for-service delivery system, and we have a managed care system to provide services. Medicaid, 78% of those enrolled in Medicaid are receiving their services and coverage through our managed care plans. 44% of recipients are enrolled in Medicaid are children, so people often don't realize that almost half of our population are kids and youth. 91,750 are also dually eligible for Medicare, so they're enrolled in Medicare, and this is often could be our disabled population as well as mostly our senior population. And 80% of our population lives in Clark County, and 62% of all nursing facility stays in this state are covered by Medicaid. All right, so before we dive into the budget, I did want to talk about a few accomplishments that the department or the division has achieved since I think Suzanne Bierman and others sat here before you last session. Since then, we have received recently federal approval of our Section 1115 waiver from the federal government. We're very excited about this. It allows Nevada Medicaid to be able to reimburse for substance use disorder treatment in our institutions for mental disease. You may refer to them as IMDs. This is more than 16 beds. So if a center that's a residential treatment center has more than 16 beds, today we would not be able to cover those services. Medicaid prohibits that at the federal level. This waiver allows us to cover those services. We hope that providers, once we get our implementation plan approved by CMS, that providers can start billing for these services in June of this year. We also received about $1.5 million in federal planning grants from the federal government. These grants are aimed at increasing behavioral health provider capacity with respect to mobile crisis services and substance use treatment. We've also expanded consumer choice in our managed care program with an additional fourth plan. This fourth plan is Molina, and the other three plans that have been in our program are HPN, Health Plan of Nevada, Silver Summit, and Anthem. We also, in our managed care contracts, we added a lot of things to those contracts, but one thing I wanted to note here today is that we added a quality incentive payment. It acts as a withhold, a 1.5% withhold on all of their capitation payments for the year, and if they meet certain quality metrics or meet certain goals for our population, they receive that funding. And if they don't, they do not receive that 1.5%. Many states are using this as a way to promote quality in the program. We also added coverage of community health workers and doulas, in addition to providing funding for the first tribal federally qualified health center. We also received $54.7 million in American Rescue Plan Act funds from the federal government. These were the reinvestment funds that support our home and community-based services programs. We also recently submitted a request to cover housing supports and services in addition to meals and other nutritional services at no cost to the state through our managed care program. We're hopeful that that will be approved in the coming months. All right, flipped too soon. We also wanted to provide today an update from the federal level, something that impacts our budget and coverage for many of the enrollees that we serve today. And this impact is the end of the federal public health emergency. You may hear us call it the unwind, the PHE unwind. And what that means is that we will be unwinding from some of the requirements that this public health emergency put upon states, especially Medicaid programs. So during the federal PHE, which started about 30 months ago, federal law required that states maintain continuous coverage for Medicaid members, which means we stopped redetermining people on a regular basis like we typically would. The goal made sense, right? It's about making sure people had coverage during the pandemic and they did not lose a provider. And this was regardless of changes in eligibility. And in return for doing that, states were able to receive an enhanced federal match of 6.2%. And we'll talk a little bit about how much that is in a minute. But in April of this year, I think we will be starting the unwind. The federal government has been delaying it, but it does seem right now that April is the date. So April of this year, states must begin unwinding from this PHE and return to normal operations. This includes renewals and ending eligibility for individuals no longer eligible. I will say that we expect anywhere up to 200,000 people to be impacted by this change. We are working closely with our exchange partners at the exchange, as well as our eligibility partners at DWIS within our department, to ensure that Nevadans know about these changes, that their addresses are updated, and to ensure that if they are ineligible, they're able to find the appropriate coverage through the exchange or wherever they may choose to buy their coverage. This unwinding process will take place over 12 months, starting in April, until eligibility has been determined for all enrollees in Medicaid. The enhanced FMAP, so FMAP, for those of you who may not be familiar, I always have to remember there are a lot of acronyms in Medicaid. FMAP is our federal Medicaid assistance percentage match, which really tells us how much generally the federal government is going to share in the cost of the program. Generally speaking, if you want a nice average, it's about 60% in Nevada. The federal government pitches in about 60%, and we pick up the 40% of the cost each year. This FMAP has been enhanced during the PHE, and that has been a benefit to the state. It's been about a 6.2% benefit, and as you can see, in each quarter this year, it will begin to step down and decrease. We did some analysis of this number and how much this impacts the budget. It will have a general fund impact of about $120 million increase. So starting January 1, 2024, we should be back to normal operations and normal FMAP, so our normal 60%-ish. And we'll talk a little bit about what the actual 60% looks like today, but that's what we'll be looking at starting in January. All right. So before we jump into some of our caseload and our budget, I did want to mention some of our challenges. We are, like most states, challenged in Medicaid with a lot of different issues, and I would say probably this slide represents probably what most state Medicaid agencies are facing right now. The impact of the PHE unwind does come at some cost, and we just talked about that to our state budget. It also comes at a cost to people, right? Who right now think their coverage is in Medicaid and for whatever reason may not be eligible anymore. And so these two things here I think we're very much focused on right now. We have one of our deputies who's really in charge of this and really working hard. But this is something that we will all be facing and trying to make sure that everyone knows how to get coverage. The second item here, I think we all know, and I think it's been an ongoing issue, I will say in Nevada, it's very chronic, is the provider workforce shortages. This is an area I think our budget tries to get at, but with more reimbursement, and we'll talk about that in a minute. But this is a big challenge. I think it's bigger than just Medicaid, I think as all of you know, and it is something we really do need to address if we want to make sure that people enrolled in Medicaid get the services they need. Rural and urban disparities in access and outcomes is another ongoing challenge. Also, race and ethnicity disparities. Another one that I think we see in the private market, but it still impacts us in Medicaid, is the rising cost of healthcare and all the services. The costs are going up and inflation, and Medicaid is a taxpayer-funded program, and so often it's hard for us to keep up with those private costs. We also have chronic gaps in our behavioral health care continuum for children with intensive behavioral health needs. We also are struggling with children in our foster care system to ensure that they have the right services they need, especially behavioral health care. And I think, like you'll hear from most divisions and agencies over the coming days, is that we have ongoing state staffing shortages. In Medicaid, we have about a 17% vacancy rate, which is about 15 full-time employees. I know that may sound small compared to some divisions or agencies, but it truly has an impact on our work. We have a lot of work to be done, and I think many of our staff are doing more than one job at a time. This slide here looks at our Medicaid caseload. So our budget in Medicaid is really founded on our Medicaid caseload and the projections around that and what we expect to spend on this population. So as you can see in the last biennium in the blue, over time, this has spiked. And this is really because of that public health emergency that I mentioned earlier, where we were no longer redetermining individuals to ensure that they had coverage and access to care. That is going away. And so as you can see, that spike starts to drop off this year and go down. And like I said earlier, it could be anywhere up to 200,000 people may see a change in coverage. So I think we're, right now hoping it will be at about 882,000 in 2025. But, it just depends on how how the unwinding goes. I would also note that we did go I think the program has, like I said earlier, almost doubled, right? A 42% increase in our program over those last few months, which is a huge increase for Medicaid, right? The people enrolled. This slide shows our projected checkup caseload for our state's CHIP program. Our CHIP program is our Children's Health Insurance Program, so it's different than Medicaid in that it still is funded by state and federal funds. It has a match as well, but this program is available to families with children to cover their children who are uninsured. And when I mean uninsured, they're not covered by private insurance, they can't afford it, or they're not covered by Medicaid. Families pay a moderate premium, a quarterly premium, in return for coverage for their children in this program. And as you can see, this program is going up over time as more people are enrolling. This slide shows our waiver caseloads and the projected wait list for Nevada's 3 home and community-based services programs. These are optional services, so we have to have waivers to provide these services through our Medicaid program. So home and community-based services, generally speaking, are provided in Nevada for 3 populations: the senior population, the frail and elderly, individuals with intellectual disabilities, and our individuals with physical disabilities. These are 3 separate programs and 3 separate waivers. Since late calendar year 2021, our waiver caseloads have fallen, while our wait lists, though, have grown significantly. Although funding is available to support this program and many of these Medicaid recipients on wait lists, provider capacity and shortages have really impacted this program. So while people are covered, they cannot get the services they need and the providers. You'll hear about this more from our sister division, ADSD, soon with their presentation, but our division's budget does invest about $150 million in trying to address this problem in both trying to address the provider capacity issues in addition to paying for very new waiver slots to open those wait lists up to allow more people to be covered. This slide here is the slide that shows our funding for Medicaid. So Medicaid has 3 buckets of funding, and this is our spending, essentially. So as you can see, for the last biennium, we have the 3 buckets of spending. The blue, the lighter blue, is the state funds. That's the portion that we pay as a state for the Medicaid program. The darker color there is the federal share. So as you can see, it does grow in the next biennium as well, and we'll talk a little bit about that in a second. And then in the other category, the gray, is the other funds that do support the Medicaid program. This could be, for example, provider fees. And we have one for nursing facilities, which allows us to pay them in supplemental payments. We will talk a little bit here in a second about a new provider fee for private hospitals. That there is also an increase for that funding. And also you'll see in here a local intergovernmental transfers to help draw down federal share for counties and other hospitals that are served by these funds. So that's the bucket. Over the next biennium, this budget is expected to grow about 30%. That is primarily because of this new private hospital fee that we are working on with the Nevada Hospital Association. And then also, you will see the state share portion is growing as well, the state general fund, by about 20%, and that is because of the changes in FMAP that I mentioned earlier, and we'll talk look a little closer at those issues here in a second. But as you can see, for the next biennium, like I mentioned earlier, it's about $16.4 billion. And I would note, I forgot to mention this earlier, that of this pie, about 40% is spent on our managed care program, and that serves about 700,000 people. The remaining 200,000-ish are fee-for-service, and that's the remaining 60% of the cost of the program. This slide here represents what we were talking about. So just so I can, let's see, I'll start with the state fiscal year 2022. As you can see, we started out with a FMAP of 62.7%. And then because we did the continuous enrollment under the public health emergency, that's in that green portion, we got that enhanced federal match. And that brought us to about 69%. You can see that there. That's increased funding, and that funding stayed with us for about, for the last biennium. And over time, as we move out of this unwind, we will be reducing that. And as you can see in this slide, as you get closer down to state fiscal year 2025, that goes down, that enhanced match is gone, and it gets down to 61.57%. I will note that our FMAP generally, without the enhanced match, did go down because our per capita income, as compared to the national average, did go up in Nevada. So that's how FMAP is determined by the federal government. So it did reduce us down by about a percentage. So just want to note that. This slide here represents our biennium budget account summary. We have 7 accounts, and one of them is new. Just want to point out that 3177, Improve Healthcare Quality and Access, is our provider fee for the private hospitals that we'll talk about here in a second in more detail, but this represents that new account where we would be collecting the fee and using that to make new supplemental payments to private hospitals in the state. All right, so now we're going to dive into some of the key specifics of the budget and some of the major enhancements. The first one, the governor recommends improving several areas that really get at access to care. The first one is for pregnant women. So in Nevada, currently, women who are pregnant are eligible for Medicaid up to 65% of poverty. This would expand that to 200% of poverty. Just for a little context, this would allow a mother now, if this is passed, who makes a single mom who's pregnant, who makes $36,000 a year, eligible for the program. That would be the limit. This would also help about 7,000 pregnant women. It would increase coverage for about 7,000 moms, as well as 7,000 newborns. So any newborn who's born to a mother who's enrolled in Medicaid is eligible for Medicaid for a year after birth. So it'd be about 14,000 new members if you include the babies that are born to the mothers. Also in this budget, the governor is recommending about $254 million in rate increases for providers. 80 million of that would be state share. The first 2 here are really critical to our primary care work, and trying to ensure that people get preventative services and really trying to get at access. And that is our physicians for 5% rate increase, dentists get a 5% rate increase under this budget proposal, as well as our skilled nursing facilities. This really, I think, gets at some of the issues we're hearing from our hospitals who are struggling with patients who should not be in their inpatient setting, who need to be moved out into a skilled nursing facility setting. We're hopeful that this will help open up more of those beds for hospitals. Another item here I just wanted to mention earlier, we talked a little bit about the home and community-based services. This effort here to increase personal care attendants' wages by 42% is really aimed at trying to increase that workforce and address that workforce shortage. We're also going to be funding or requesting that the governor's requesting that the legislature fund rate parity for advanced practice registered nurses and certified nurse midwives with physicians. So that would bring help increase also access in our rural areas who are having issues finding physicians to serve the population. We're also looking at, the governor's recommending a rate increase for providers of services to individuals with intellectual disabilities. And this portion here is about $35 million in the biennium, and it gets at to the home and community-based waiver programs, trying to help increase provider capacity. All right, so now we're going to talk about 2 more items that the governor is recommending that really are trying to get at access. The first one is the new private hospital provider fee. Currently under state law, if a majority of medical operators, which in this case hospitals, vote and agree to a provider fee, our division, our director, can impose a fee. We use that funding under state law to pay for new supplemental payments. That state funding draws down federal share if we do that tax appropriately under federal law. And that money would be used to pay private hospitals, about 55 private hospitals. It would result in a rate increase in total of about $1 billion. So it's a big infusion of funds for our hospital system. As we all know, it's needed. And this is a project we've been working on with the Nevada Hospital Association over the last 6 months. Trying to get this off the ground. It is a big lift. So that is why, as you can see here today, we included several new positions that we need at the department to ensure that this is done right, because it is a lot of money. And there are a lot of federal requirements and auditing that go into this program. And we want to make sure when we do this, that we do it right and it works for the hospitals as well. The second item I would like to mention this morning, it's really trying to get at access to care, is looking at modernizing our supplemental payment programs. Some of these efforts include changing the model for our disproportionate share hospital program, which is our DISH program, and also changing some of the FMAP claiming for Clark County. The goal of this program is to really balance the needs of the state budget in addition to the county budget, and ensuring that the participating hospitals are not harmed by this effort. I will say it's a very delicate approach to try to address the county needs of ensuring it's viable for them as well from a budget perspective, and ensuring that all the hospitals benefiting today, the 23 hospitals, do not see any changes in their payments. And I will say we were able to achieve that here today. The next slide here walks through some of the items the governor is recommending to promote behavioral health care in the state through the Medicaid program. I will note that this is about $23 million in the next biennium in state share. The first one is expanding the number of certified community behavioral health clinics in the state from 9 to 15. So CCBHCs, as what you might have heard them referred to as, they are really important to integrating our behavioral health care services into our regular health care services. In these clinics, they're specialty clinics that include substance use treatment, mental health services, and primary care, in addition to mobile crisis and a lot of case management, care coordination, all under one roof. So it's a really nice integrated model that we're trying to promote and increase access to for our members. This request includes several positions that are needed to ensure that we can support providers and run this program. We are also funding the ongoing continuation of the children's behavioral health initiatives that are funded right now by ARPA in collaboration with our sister division, the Division of Child and Family Services, and you'll hear more about those later today. And then the next slide is a couple items that the governor is recommending around, the first two here are around strengthening our managed care program. The first one is funding the statewide managed care expansion and making sure that we have the staff and the contractual support to do that effort and to do it well and to ensure that it works for everyone. The second item here is funding more expert contracts and expertise. As we struggle with staffing, our vendors and our experts, especially our contracted actuaries, come in, are very, very much useful to our work, and we rely on them a lot. This request includes helping us with requests for proposals to make sure our contracts are done well, as well as supporting our managed care program and our rate development process. The last item here is around healthcare transparency. There are two items I would note today for you to look at, and the first one is really looking at improving participation in our state certified health information exchange, or HIE. This is really important if we really want to see providers do care coordination, population health management, if they really want to be able to see what's going on with their patients and help them manage their care. Improving the number of providers that participate in this data sharing program is really important. I would also note that our all payers claims database, we have some funding requests in here. I know this was passed last session. The hope was that we would get some federal funding that should have been available to states for this effort, but it ended up not coming through. And so we're coming back this session to ask for some implementation and ongoing costs to support this effort. And this is really important too, as we look at the cost of healthcare and understanding how all of our markets play and interact together. The APCD will play a very important role in understanding cost. And last but not least is our program infrastructure enhancements. I know sometimes it's not always the thing to ask for is more FTEs, but I will say we do need them. We need more staff capacity to support our fair hearings process and team. We're asking for one more staff to support that effort. We're also asking for increased staff for our division's fiscal unit and our information technology and our HR unit. And this is because we have more responsibilities as the program has grown and payments are growing and more activities that we need to make sure we're doing well and that we're in compliance with all state and federal laws. We also are asking to add a pharmacist to provide the needed expertise to our division's pharmacy team. This is a growing cost driver in our Medicaid program, and we really think a pharmacist would be helpful to that work. And the last item here are just other initiatives I did want to note. I think some of these might have come up earlier, but the first one here is coverage of wearable cardio defibrillators and supplies. There's funding in the budget for those items, as well as continuing the ARPA-funded dental program for individuals with intellectual developmental disabilities. And we recently got that funding and are working to set that program up. So this funding would just continue that funding and hopefully draw down Medicaid share. Federal share. And the last slide here is the governor's recommending that from our base here that we reduce our base and FTEs by 16. So as you can see, the governor's recommendation is 323.51 FTEs at our division. And then I'm going to open it up for questions.
Thank you very much. First question, I believe, comes from Assemblywoman Nguyen.
It's okay. I know who I am.
I apologize. I just had a moment lapse of memory there.
That's okay.
Welcome
That's
to
okay.
the team, Senator Nguyen.
That pay cut, now this. No. Hi. Good morning. Thank you for that presentation. And thank you, Ms. Weeks. I know that we have been talking about the provider tax for a very long time, and you have been wonderful, to be quite honest. So I have a couple of questions for members here, because I know some people kind of understand the provider fee. And that's just I'm doing a lot of talking, but you can respond, hopefully.
Okay.
Yes, you're right. The provider fee is already in statute, and it has enabling language. Is that the way it is currently set up in statute?
Chair, committee members, yes.
Okay. And it currently exists for like long-term care facilities. I think you already mentioned that.
Chair, committee member Stacy Weeks for the record. Yes, but it's a separate statute. So there's a body of law that's focused on the nursing facilities. This other one is focused on a polling system where medical operators by license type can be polled to see if 67% support the fee, and then the fee can be implemented.
So it was mandated on long-term care facilities, and with hospitals, it was a kind of enabling if they got that critical mass, I guess.
Chair, committee member Stacy Weeks for the record, yes.
And so essentially what it is the hospitals, in applying for this and, working through this process, they have the numbers, and now they are going to voluntarily tax themselves. Is that correct?
Chair, committee members, yes. I will note, though, that we ourselves have to do the polling, too. They did poll themselves, but we will be doing the polling as well after session of hospitals. But yes, after if the vote is 67% by license type, we can move forward with the tax. And yes, they are voluntarily, at that point, offering to be taxed.
And so just to dumb this down for myself as well as other people, I know this gets really complex. Essentially, that money is taken and it is matched federally, at a 3-to-1. Is that about right?
Chair, committee member Stacy Weeks for the record, it's 60-40 depending on the population. But yeah, so we would be, the revenue be used for the state share and be drawing down about $1 billion.
Okay.
In total.
And you had talked about how there were budget increases in here for staff to administer such a program. And this is a huge amount that we're potentially talking about. Is that correct?
Chair, committee member Stacy Weeks for the record, yes.
But if it was to get up and running, it would later become self-managing, and those funds could be used potentially to fund the people that administer the program.
Chair, committee member Stacy Weeks for the record. Yes, I'm glad you brought that up. I apologize we did not mention that. So once we get the revenue, we do, under state law, have the ability to use that money to pay for staffing and administrative costs. So that would be part of our proposal.
And I feel like I'm cross-examining you. I feel really bad. I'm
it.
feeling the lawyer in myself come out here, so I apologize for everyone. When you talk about that money coming back, obviously there's some fears that we are going to just take that money as a legislative body. Is that correct?
Chair, committee member Stacy Weeks for the record. I can't speak on behalf of the hospitals, but I will say that statute is very explicit about what the funds can be used for and can't be used for. And so that, in many ways, you'd have to change statute.
Okay, and so does that money that potentially would come back in matching funds, does it go all directly to the hospital, or are there quality of care issues that we can like build into how that is, or is that what you're in the process of doing?
Chair, committee member Stacy Weeks for the record. At this time in the first year, we're not looking at withholding any of the funds for quality. We can, and if we want to, as a state in the future. But at this time, we'll be focused on definitely monitoring quality, but we will not be withholding any funds based on performance.
And when do you put in a percentage of how much is held back for administration, though?
Chair, committee member Stacy Weeks for the record. Yes.
Okay, and then. If I know that there are some other people that are also qualified potentially, or other types of industry within the healthcare community that qualify for a provider fee like situations. So I know like ambulatory services want to be included, and they want to be able to tax themselves and like administer that. If there was legislation that was to be introduced, would you need additional bodies to like also administer those kind of provider fee programs?
Chair, committee members, Stacy Weeks for the record. It's hard to say, depends on how big the payments are. Hopefully, once we have this infrastructure built with these new staff, that we'd be able to take on. But I don't want to speak to that without, talking to my team. But I do think building that infrastructure is what the goal of this is so we can support more directed payments and supplemental fees and taxes, or provider fees. Yes.
Thank you. And I do apologize. I realized I was crossing.
Assemblywoman Anderson, now Assemblywoman.
Thank you, Chair, and thank you, Director Weeks, for the presentation as well as the cross-examination exercise. That was fun to watch. But it was actually very educational, so really appreciated it. I do have a few questions. I'll try to make them just one or two. The first has to do actually with slide number 9 with the ongoing challenges. You said that you have a 17% vacancy rate and 15 people, and then one of the last slides said that there was a recommendation for a reduction. How would that impact, would that just be those 15 people would be gone? Or how would that impact the current overwork of your department?
Chair, committee member Stacy Weeks for the record. So just so make sure I said that clearly. Sorry, my throat. 17% vacancy rate right now, 50 employees, sorry. Yeah. And the governor's recommending, I think, a reduction of 16. And those were positions that were not filled before, so the impact is hard to know since we didn't have them. These are positions that were determined as unnecessary ongoing.
Thank you. A separate question, Chair, if I may.
Go ahead, please.
Thank you. This actually had to do with slide number 4, your organizational chart. And there's so many different services that each of your deputy administrators have to utilize. But I don't see anything that is specific for mental health. And yet you did mention it later, and that is a huge concern, I know, for many individuals in our state, and also, and you mentioned it many times in your presentation. So is mental health just used throughout, or is it under a different title?
Chair, committee members, Stacy Weeks for the record. That is a really good question. We have a lot of really important services. We do have behavioral health, though, under Dr. Capurro. But I will say we have a chief who is over that program, Sarah Dearborn, and there's an entire unit that she oversees for that work. But it does look buried in this chart. Someday maybe we'll bring the full chart for you. It's pretty large, but I apologize that it looks buried. It is very important, and it is something that it does take up a lot of our time, and it's a very big piece of our work.
Thank you. And my final question, I promise. You mentioned trying to do some different type of support systems for our individuals. I know that in northern Nevada, and I believe also in other areas of the state, there are some different types of therapy, such as music therapy. Is that also covered under Medicare, or is that a Medicaid, excuse me, or is that a different area of the health system?
Chair, committee members, Stacy Weeks for the record. At this time, my understanding is music therapy is not currently a covered benefit. It would be optional that if the state wants, if the lawmakers and governor want us to fund that, we would need to have funding appropriated, the state share portion to fund that service.
Thank you, Chair, and thank you for those answers.
Yes, thank you.
Thank you very much. Assemblywoman Brown-May.
Thank you, Madam Chair. Thank you for your presentation. I just have two quick questions. First, I have to say thank you for answering my previous question relative to the FMAP unwinding and what are the dates associated with that. Secondarily, it's my understanding that we have redetermination for all eligibility for Medicaid. And so if we have 912,000 people that are currently covered by Medicaid, I can imagine that that's going to be a significant lift by the division to be able to do the redetermination. Are we at risk of losing any of the federal match dollars if we don't do it within a specific time frame?
Chair, committee members, that would be our Division of Welfare and Supportive Services, so DWIS. So I think they can speak to that more clearly. But I think we expect that we can meet that time frame. We've been planning over the last 6 to 9 months and do have a plan. So at this point, I don't think we're, but I would let them speak to the federal match. I apologize, I don't have that with me.
Thank you for that. It appears my questions are always for the wrong person.
Sorry.
But I'll get better
Thank
at that, I promise. I do have one second question. There are a number of significant rate increases that are addressed in this budget. And in my recollection, really unprecedented, I think, as Director Whitley said earlier today. And I apologize if I missed it. There's one rate in particular for healthy babies. We talk about all of our pregnant moms that are really covered by Medicaid. Do you know, is there a neonatal intensive care rate that's addressed in this budget that maybe I just missed?
Chair, committee member, Stacy Weeks for the record. No, there is not.
Thank you.
Thank you very much. Senator Neal.
Thank you, Madam Chair. So I had a question on page 16 with the dentist plus 5%. So did services increase as under this that they will be offering?
Chair, committee members, Stacy Weeks for the record. No, it's just a rate increase for the current services that are covered under Medicaid.
So it's still cavities and, well, it's not even cavities. It's getting your teeth pulled and getting them cleaned. Yes.
Chair, committee member, Stacy Weeks for the record. It depends on the population. So yes, currently Nevada Medicaid does not cover adults. The legislature has not funded that population for dental services. Some states do cover adults, and so for those services, it would be limited to emergency services and to some basic services. And then pregnancy, we do cover a broader set of benefits for pregnant women, and we do, under federal law, have to cover children. So those would be a broader set of services as well.
Okay. And then my second question is on page 18 on the continuation of behavioral health initiatives. So it's funded with ARPA in collaboration. But when will the ARPA funding end?
Chair, committee member, Stacy Weeks for the record. I think it varies by project, so I would let Dr. Pitlock address hers in specifically, but I would say generally we have about 2 years, but I don't want to misstate that on her project specifically.
Because I'm wondering, so the governor has mentioned that he didn't want to continue over-reliance on federal funds, so what are you guys looking at in order to offset your combination here, if there's a reluctance for federal money to be infused? Or are you guys safe? You're the one agency where you can go after the federal money.
Chair, committee members, Stacy Weeks for the record. Medicaid is a federal state funded program regardless, and so the hope here is to maximize the money that we can receive and the match to pay for these services.
Thank you, Madam Chair.
Thank you. Senator Titus.
Thank you, Madam Chair, for the questions. I am a physician, not an attorney, so I will not ask you the questions in the same order as my colleague to the right did. I have a couple questions, but first, a thank you. You've been incredibly responsive to my questions when I've reached out for information, and I think information is the key, and sharing information helps a lot to dispel myths and assumptions. The other thing is, I am a Medicaid provider, and recently, and I've been a Medicaid provider since 1982. That's how old of a doc I am, and recently had to renew my contract, and it was the biggest obstacle I've ever had in any application process in my life. And so just so you know, and I finally, and your folks that I finally did get on the phone were incredibly helpful, but my frustration was very evident when I'd say, hey, I'm a willing provider to sign up for Medicaid. You should say, how can we help? And instead of all the barriers. So just throwing that out there. Then some real questions. You mentioned that you're giving something like on page 16, a 200% changing pregnant women on poverty level. We've had multiple discussions in this committee and in our healthcare committee about presumptive eligibility. I see the critical need to make sure the babies come out healthy, not just take care of them afterwards. And I worry that sometimes the state assumes responsibility just at the birth, and then it's a little bit too late. So are we having any discussion on continuation of expanding or encouraging presumptive eligibility? And if that needs to have a different discussion, I'm happy to go there. But just want to make sure that that's still something that's really in mind, because I see it as a real need.
Chair, committee members, Stacy Weeks for the record. I would defer to my colleague, Dr. Capurro, on the presumptive eligibility. I want to say we are implementing some efforts around that, but I could be wrong. I want to make sure I don't get that wrong. Dr. Capurro, could you come up? Is that okay, Chair? Yes, thank you. She's in the Sawyer, Grant Sawyer building.
Good morning. Chair and committee members, yes, that's correct. We are implementing presumptive eligibility with our sister agency, JWIS, and we'll have more information coming out shortly that will be available for providers and the public, and we'd be happy to share that with you.
Great, thank you. Looking at the numbers that 55% of all births are covered by Medicaid, I mean, I'm just so interested in, and it's just critical. Now back to some finance. You mentioned the FMAP, and we're having a clearer discussion with the federal agencies on when that might end. Over the last two sessions and during the COVID pandemic, the FMAP was continued way past what we thought it would be. And I'm curious to see, and we ended up with a surplus at one point because we continue to have that FMAP extension. Now you gave us kind of a clearer date that they're giving you that it's going to end. What was the surplus that we ended up with? And will that offset that $120 million you think that the general funds are going to have to come up with?
Chair, committee members, Stacy Weeks for the record. I'm going to defer to Deputy Administrator Lynette Aaron to answer that question.
Hi, for the record, Lynette Aaron. I don't have those numbers at this time, but I can definitely get that for you, what we anticipate in surplus for fiscal year 23.
Great, thank you, because I think that's really, we need to know that number just to know that offset of where we're going to be, but we're actually starting from a higher point than we thought we would be because of the extenuation, the extension of the FMAP. And then the next question, and last question, if I might, Madam Chair. So this committee, people who've been on this committee have heard me asked these questions in the past regarding the number of Medicaid enrollees. And on your early maps, you looked at how we're going to kind of unwind with the Medicaid enrollees. And we had a tremendous increase during the pandemic of people that enrolled. But I've mentioned, and I've said this before, just because we had Medicaid enrollees, that didn't mean they actually got medical care. And we actually saw a decrease in patients in the offices during that period of time. And I've asked for those numbers in the past about what actually people were enrolled, but they never sought care for a number of reasons. Distrust, or they couldn't get in, or months waiting because, nobody wanted to see Medicaid, and the people didn't want to see a doc. And so I'm just curious as to what those figures are, and I'd still like to see those figures of people that were actually enrolled versus people who actually access the care.
Chair, committee members, Stacy Weeks for the record. I'd like to defer to my colleague Kyra.
Good morning. I'm Kyra Morgan. For the record, I'm the Chief Biostatistician for the Department of Health and Human Services. I don't have in front of me anything that looks at total enrollment and utilization, but what I do have prepared is an estimate of individuals who we know are likely to lose coverage due to excess eligibility. And of those individuals that we expect to lose coverage, we do show that 86% of them have utilization history in the last year.
Good to know, thank you. And along that same line, you were going to, the department, not you personally, but the department was going to renegotiate, because the majority of it is through managed care organizations. And during that time when I think the managed care organizations probably were one of the small niches in healthcare that made money probably with their enrollments and the contracts. I'm just wondering, have you renegotiated the contracts along that line with the Medicaid providers? And if so, is that available information anywhere?
Chair, committee members, Stacy Weeks for the record. So when it comes to our managed care plans, we are currently still in the current contract, which ends December 31st, 2025. I will say that each year we do set the rates. So we do look at utilization and spending. And this year there was a rate cut because of some of those issues. So we came in at about a 6% rate cut. We did offer some incentive programs. So if they spend more money on primary care, for example, on providers, that we will give them a bonus payment to help mitigate some of those impacts. We also ask that they spend some more effort with their providers in value-based payment design. And if they do meet some targets around that, they can also buy back some of that cut. But we wanted to make sure that those issues were addressed, but that providers don't see any rate cuts. That was our concern. But I will say each year we do essentially reset the rates with our actuaries. So that I think that's trying to get at the problem that you're mentioning.
Great, thank you. And I just want to end by thanking all of you for the heavy lift that you have. It's frequently people mostly complain, but I know that it's incredibly difficult. And when you're trying to maneuver through the federal regulations and help our constituents and the citizens of Nevada, I think that you are amazing at what you do. So thank you very much.
Thank you.
Thank you very much. I have one question, and that is there any plan to have any additional, like CCBHC in Southern Nevada, where we have a lot more population? Is there any plan to enhance that or to make more centers? Or I think currently we only have one provider.
Mm-hmm. Chair, committee members, Stacy Weeks for the record. Our hope is by opening this up to 15 providers instead of 9, that we'll be able to have more providers across the state of Nevada.
Thank you. I hope that those more across the state of Nevada end up in Southern Nevada.
Yes.
Thank you very much. And back to the question on those that will be losing the ability to have a provider. Is there a map or anything that keeps that we could look at to see where those people are going to be that who will lose care?
Chair, committee member, Stacy Weeks for the record. I'd like to call my colleague back up, Kyra Morgan, who has more of the data and analytics around that population, to see if she knows anything about geographic projections.
Thank you.
Hello again. For the record, I'm Kyra Morgan. I'm the Chief Biostatistician for the Department of Health and Human Services. And yes, we can absolutely map those individuals once we figure out who they are.
Thank you. That would be helpful. And I think maybe to close up our question time, Assemblywoman Anderson.
Thank you, Chair, for giving me this time. Based upon some other questions that were asked, I was just taking a look at page 16 with the provider rate increases and just wondering, how does the provider rate increase, how how is that impacted with the possible statewide managed care program that is mentioned in page 19? And that's kind of question number one, but then also question number two, is this rate increase on par with what is happening across the nation in this field, in all of these fields?
Madam Chair, committee member Stacy Weeks for the record. Those are very good questions. So with the statewide managed care currently in statute, so this was passed as part of Senate Bill 420 last session. As part of that statute, there is a provision in there that is trying to get at the providers in the rural areas. I think that you're concerned about rates, right? Because in managed care plans set the rates with their providers. They negotiate their rates, whereas fee-for-service, we essentially set a fee schedule or we do cost-based rates, et cetera. But managed care plans have a lot of freedom in that way. But in the statute, it does require us to do directed payments, which would essentially set the rates for many of the providers in the rural areas, especially for our federally qualified health plans, which are critical providers in those areas, and our critical access hospitals, and I want to say the rural hospitals as well. But all of those are going to be getting directed payments through managed care, which would be, we could set the rate, and it's based on the current fee schedule. So it would not be going up necessarily, but it definitely would not be going down from where they are today. And then the second question you asked, yes, I think the goal of a lot of these rate increases is to try to get the state into more of the national rates. Sometimes it's hard to tell, though, nationally what providers are being paid, but based on our quadrennial rate review that our department does, which is statutorily required, we were looking at other states, and a lot of these here today are reflective of those recommendations about what we need to do to address cost, as well as be closer to other states in our region. Thanks.
Thank you very much, and thank you to all of you for being here today and all the hard work that you're doing. And once again, we're sorry for your loss.
Thank you. Thank you, Madam Chair, committee members.
Thank you very much. We'll be moving on to agenda item 5, and this will be the Division of Welfare and Supportive Services, and Administrator Robert Thompson will be joining us. So when you're ready, please go ahead.
Good morning, Madam Chair, committee members. For the record, I'm Robert Thompson. I'm the Administrator for the Division of Welfare and Supportive Services. I have with me today Deputy Administrator Kelly Cantrell, Deputy Administrator Lisa Swearingen, and our Agency Manager over Child Care, Carissa Loper. As we go into our presentation, we've added on slide 2, just to give you a snapshot of our mission statement. On slide 3 is our organizational chart. Our true organizational chart is about 100 pages long. This is a snapshot. We have approximately 2,400 employees. So as you see under these little tiny charts that these ladies run their units all day long, there are hundreds, if not thousands, of people in these little boxes. On the next slide, slide 4, we start talking about our summary of our agency operations. Our primary agency operation is eligibility. We do eligibility and payments and policy for the Temporary Assistance for Needy Families, commonly known as welfare. Supplemental Nutrition Assistance Program, shorthanded to SNAP, but often referred to as food stamps. Medicaid, which we heard about a lot today. We do the eligibility for the Medicaid, and we'll talk about that a little bit later. We do child care development eligibility and energy assistance. Within our agency, we also have program outreach. Historically, if a Nevadan needed to access our services, they were required to come into a brick and mortar building, fill out about 25 pieces of paper that said their life story, and then we reviewed that. That's how I learned how to do the eligibility in 1996. And since then, we have streamlined and made it easier electronically, but we also go out into the community, and our outreach services connect our eligibility workers where we are needed out in the community. We send eligibility workers to mental health facilities, correction facilities, courthouses, where we are needed. We actually have a wait list for this program at this time. But what we've really found is we're able to connect where we're needed without people having to come to us. Sometimes the homeless shelters, right? They don't necessarily have the transportation, so we infuse those services throughout Nevada. We do employment and training. Our employment and training is primarily targeted to our TANF welfare population, but it also is, there's an infusion there with our food stamp population also, or somebody that could potentially be on food stamps. And we talk about that population. We're able to get very creative to provide employment and training to just about anyone who needs it. The next slide, on slide 5, we talk more about our summary. We do program oversight, and I think it's very important that we talk about in every program that we run, we want it done correctly. We are measured by ourselves, and we are measured by the federal government to make sure your tax dollars are spent correctly. We do the eligibility down to the dollar to determine how much someone can receive, whether that's Medicaid, food stamps, cash, energy assistance, child care, whichever program they're applying for. But we actually do more than just that individual assessment on whether somebody is telling the truth. We have to do case reviews of our own workers to make sure those cases are correct. We've also worked with law enforcement, such as working with the FBI when there is food stamp trafficking or identity fraud. So it's a huge department, and it's almost like a tiny little police department and quality department within the welfare division. We do child support enforcement, and child support enforcement is just that. Children need to be supported by both of their parents. One parent is not receiving their child support. We connect with that parent. They apply for our services. We establish the support. We locate the non-custodial parent. We establish financial and medical support orders, and we enforce those orders. And we also have administrative services, which is human resources, IT, fiscal, and that foundation of the agency to make sure everybody is able to move forward with their jobs. On the next slide, slide 6, we start talking about our division priorities. And in our division priorities, we're first and foremost, we're the safety net. We are the safety net for Nevadans who have food insecurity, who are not able to maintain basic needs for their children, to keep their children in the home, or obtain their medical need through our sister division, Division of Healthcare, Finance, and Policy. So our first priority is to be that safety net while maintaining the integrity, accuracy, and efficiency, and addressing that fraud that we talked about. Our second priority is always workforce assistance and support services. And we talk about our support services. Without those support services, we don't have workforce assistance. If we don't have assistance with transportation or buying your work clothes or your work card or childcare, which is a huge piece of what we do, we're not able to infuse those Nevadans into their path of careers. And we also provide that pipeline for Nevadan retailers, Nevadan job markets, the providers and vendors. We provide them with employees. We work with collaboration and public health. We work as hard as we can to break down silos between our agencies. It wasn't necessarily always that way. Director Whitley is huge about breaking down those silos and not duplicating efforts. And everything we do, we work to make sure we are supporting a healthy Nevada. Our infrastructure is always in our priorities, and that is just to make sure that we are enhancing our policies and procedures, and we have a process that we call business process reengineering, where we have a team that does nothing but making sure we're working as efficient as possible with time studies and monitoring our staff and making sure that everything we do works. We take up to, it's something like 200,000 tasks per month that we work in our agency. And we've done touches and said, if we could save 2 minutes here, what does that translate over the biennium? And we consistently do that, and we're as efficient as possible. On the next slide, we talk about our program accomplishments. We've come before you many times over many years to talk about our TANF program and our work rate participation, our work participation rates. To receive our TANF block grant without penalties, we are required to have X number of our TANF recipients working in a very complex measurement from the federal government, and we weren't necessarily always successful there. It wasn't that many years ago we came forward to you and said we were facing some $20 million in fines. We have corrected those issues. We are now meeting the work participation rate. We met the needs of the federal government for our corrective action. We are waiting for those finding letters for that fine. But we met the work participation rate for all family in federal fiscal year 2021, and all preliminary data shows that we've met it again in 2022. We just don't have the formal letters yet. Our SNAP accuracy, the federal government comes in and measures all the states on how accurate we are with the food stamp program. Nevada was last. We were last in the nation about a decade ago. And we worked very hard and we improved ourselves to 20. But in federal fiscal year 22, we increased our accuracy from 20th in the nation to 14th in the nation. So in my career in the agency, we've seen us go from the last to the 14th. So we want a shout out to our deputies and our caseworkers on all that work there. During the pandemic, we were able to issue additional food stamps to our communities. We were able to issue additional food stamps to children who missed school due to the COVID event, and we were able to issue additional emergency food stamp allotments. That was a massive amount of work for the agency to get those rules and regulations put in place and to get that money put on the cards, but it translated to almost $2 billion in federal food stamp monies coming into Nevada families that translated that into the retailers and translated that, like the farmers, the cattle, everything, right? $2 billion. $2 billion was brought in during that pandemic. Also, during the pandemic, we had a huge increase in our child care and development programs. We increased those programs, exactly child care and development, exactly what we think of it, right? We need to provide safe and reliable child care so parents can go to work. But during the pandemic, those child care centers were closing down. People weren't going to work. They were going to lose their buildings. The staff, they couldn't pay their staff. And we were able to infuse federal dollars into those child care centers so they could maintain operations even if they didn't have children there. On the next slide, we talk about our customer service accomplishments. And in our customer service accomplishments, I talked about the targeted outreach a little bit, and just to give you the number there, we service 182 community partner sites monthly. We go out into the community. Some of those are full-time, some of those might be half a day a month, but 182 a month are touched. Those are Nevadans that do not have to come into our building. We also went to 183 specialized events over the biennium, and a specialized event could be something like the homeless stand-down, and it's a one-day event, and we will send staff there. They have actually what we call office in a box. They have a laptop, a Wi-Fi, a little printer, and they can get Nevadans signed up for Medicaid and food stamps right there on the spot. Our call center team answered almost 200,000 calls from July 21 through January of 23, and our SNAP timeliness maintained at 95.68% with an average processing time of 14 days. And I'm going to pause there for a minute to really talk about that. The federal government requires that we issue all food stamps for emergency households, and that's a very specific criteria on what emergent is for the federal government, at 6 days. Non-emergent has to be approved within 29 days. Nevada, prior to the pandemic, we were processing our food stamps in around 8 days, 7 days some month, 9 days other months, and we increased, that went up to 14 days. We're still meeting the requirements of the federal government, but we are now taking an average of 2 weeks to approve those food stamps. And I have to wonder how difficult that is for a mom that doesn't have food in her pantry, what 2 weeks feels like. That increase was not a huge increase in the caseload projections. There were periods of time in there where our application count increased 3,000% during the pandemic. When all the hotels were laying everybody off, they were laid off, and within 2 weeks they were in our front door. And we were maintaining that, and we were dealing with that. But then over the pandemic, and the labor shortage started, and the vacancy rates started increasing. And we are now running on overtime most of the time to meet this. Director Whitley talked about our vacancy rates, and our vacancy rate in the welfare division is running at 18%. And 18% is 3 times higher than what it ever was when I was running field operations. But when we dig deeper into that and we start looking at the number of our case managers, the online case managers, because those are our customer service staff, those are the people that have to get those food stamps, Medicaid, and TANF approved, it takes almost a year to train them. When they come in the door, we put them through a 10-week college course, style academy, and then it takes another about 7 months to bring them up to speed to where they can work on their own. And during that 7 months, we have to have a mentor for them. And what we found is our veteran caseworkers, our highest skilled caseworkers, they do the higher skilled cases. They are doing our hearings. They are doing our medical institutional cases are very complicated. They're doing the testing of our new systems. They're doing the outreach. So then where our true vacancy rate is are those frontline entry-level caseworkers. And I did an analysis before we came to you today. While we're running about 20% vacancy in that, another 30% have less than a year with our agency. We have never been in a situation where half of our frontline staff were less than a year or vacant. And so we are struggling to train them, struggling to maintain them, and struggling to get those benefits out. So while we're at 14 days, and I am just so thankful that our staff are willing to work as hard as they are and working nights and weekends to get that done, we need to see that get back to 6 days. We need to see that get back to 7 days. So enough on that. That was my soapbox for, I won't do that again, I promise, but I needed to do that. During the pandemic, we had cross-collaboration from departments, and it was unprecedented. We saw the Department of Employment and Training Rehabilitation. We all saw in the newspaper that they couldn't keep up with their unemployment claims. The welfare division, our directors worked together and moved magic in the background. I'm still not 100% sure how they did it, but we were able to cross-collaborate, and the Department of Health and Human Services sent 200 workers on nights and weekends. They did not take away from our productivity. They worked overtime, and they processed over 500,000 claims and work items for the unemployment division. That's just amazing. Director Whitley talked a little bit about providing eligibility to inmates, and we enrolled over 2,700 inmates into that program so that they would have their Medicaid card and services upon release. And that's just fantastic to what we were talking about 2 years ago. Next slide, please. As we go into the caseload, we start talking about our projections, and we don't get into the weeds on every single little caseload that we have because it gets very complex. So this is just very high level. Our TANF projections, during the pandemic, this caseload dropped. It dropped significantly, and it was difficult to understand in the beginning because it was a nationwide event that this caseload dropped. While unemployment was skyrocketing, the TANF caseload went to all-time lows. But we realized what that was happening, what was causing that was the federal money that was being infused into the community. The child tax credits, as child tax credits rolled out, people stopped applying for that welfare, which makes sense. But we saw, even our sister state, California, that TANF kept dropping, and with the labor shortage, has not started to grow again. So we're expecting that to maintain. The next slide, please, is our SNAP projections. SNAP caseload, we continued to work SNAP all through the pandemic. There weren't, with very small pockets of time, those eligibility rules did not change from the federal government much. So what we've seen with that, besides the spike of when all the hotels closed, we've seen that caseload stay static, be about what it was expected to be, and it will continue to grow slightly. The next slide, please, the Medicaid projections, and I know there's some questions coming on the Medicaid projections, so I think I'm probably going to touch more on this during the question and answer session, but as we've heard today, we were not closing cases during the pandemic. Half of the people receiving Medicaid receive food stamps, so we never lost contact with those people because we still had to do the food stamp paperwork. So we're talking about that other half that we don't necessarily know where they are or have done their paperwork, that we'll be talking about probably during your Q&A session. But we do see that caseload start to drop, and it will take us about a year, and in some cases longer than a year, to work all of these cases again with the redetermination process. The next slide, please. Slide 12 is our child care projections. Child care projections are doing exactly what we'd hoped they would do. They are increasing. We are hoping to see more people access child care, to move more working adults back into the workforce and provide that safe and reliable child care to our children of Nevada, and this is doing what we want it to do. Next slide, please. The next slide is just a very interesting visual that we like to give during these presentations. We call it our bubble chart. These are our big three programs, and we call our big three programs SNAP, Medicaid, and TANF. And it shows the intersect of people that are accessing more than one program. So when we look at this is a snapshot in time in August of 22. We see that there are 921,000 Nevadans receiving Medicaid on this date, but we can also see of those, 406,000 are receiving SNAP. And that's what we want to see. We want to see people accessing all the services that they can so that we can stabilize those families. Not all states integrate their services, and I think that's a shout out to Nevada that in the 90s we started integrating. Some states still require an individual to go to a Medicaid office, provide their check stubs, go through the interview, and do everything they need to do to get Medicaid, and then they take a bus across town to go to the food stamp office. And Nevada integrated that in, it was the early 90s, it was before I worked here, and everything we do, we try to integrate our policies, our procedures, just to be as efficient as possible for you and for our customers. Next slide, please. The next slide is just a snapshot of our biennium budget. Looking at GovRec for 24-25, slightly over $1 billion. But I do want to point out this does not include the food stamps. Food stamps, we are a pass-through agency from the federal government. The $2 billion that we gave out in food stamps is not listed here. That will drop. That $2 billion was due to pandemic funding. Prior to the pandemic, we were giving out about, we were approving about $700 million a year. So I would say we could estimate that to go back to the $700 to $900 million mark. So just showing that with the $223 million investment in general fund, we then bring this into Nevada's economy. The next slide, please, is a breakout of our 8 budgets. We have 8 budgets to run our 6 programs. Some of our programs have more than one budget, and it's just this, an itemized snapshot of where the funding will go per budget account. On the next slide, we start talking about our one-shot initiatives, and our big bang for our bucks is our computer systems are antiquated, and they're starting to, for lack of a better word, crash. We're having difficulty keeping them serviced and up and running, and our 3 main requests are to update those systems, hardware, software, technology, to support everything we do in an efficient manner. When we don't have the technology, we go back to paper methods, and it takes 5 times as longer with 5 times the staff. The next slide, please, is a summary of our major enhancement requests. And we are requesting don't know if you've heard of nomads. We've talked about nomads for years in these committees. Nomads is an old green screen system. It was never designed to live as long as it's lived, and we are asking to update and modernize that. We have a No Wrong Door project to integrate services throughout Health and Human Services. We have a child care system update request for an eligibility engine and to assist our external partners. And we have an Access Nevada system. It is our electronic system that our customers can apply for benefits online. And we'd like to update that to allow customers to access their notices and documents without having to call in or come in. Next slide, please. As we've heard from our other divisions, there are some requested positions. We've noticed through the years, through these sessions, when there's a need in our agency to expand the agency, we always target those case managers. We've always been able to show that we need case managers, supervisors, and managers for the frontline staff, but we have not expanded our infrastructure to support them. And the federal government is putting a massive amount of new requirements in for our reporting to be able to keep accessing those computer systems. And our security requirements are much higher than they've ever been. And we all hear about that, this cyber attacks and those things that happen. And we do need to increase our staffing in the area of information technology. We have almost 2,400 employees, and we have only 2 deputy administrators. These guys are getting really tired. We are hoping you'll support us for an additional deputy administrator. And on the next slide, we see that administrative services, our fiscal services, our employment support services needs 1 person. And our child care development, that program, the funds that are moving through there and the oversight and the contracts that they're working on, we never anticipated the level of work that is coming through there. So we are asking to increase our child care development program. And on the next slide, there's a snapshot of those summaries. While we're requesting 49 additional positions and enhancements, we always have slight updates in our request for staffing in field services. That's tied to caseload. The governor recommends reducing 43 staff from our field services with an increase of 49, so it's an overall increase of 6. While we will open up for questions, I do want to point out that we have an appendix with all of our acronyms. We are heavy on acronyms, and it has been requested in the last couple presentations that we include our source and use documents for our TANF block grant and our child care, so we've put those in for reference so you don't have to ask for them. And we are now open for any questions.
Thank you very much for that presentation. We'll start with Assemblywoman Brown-May, please.
Thank you, Madam Chair. Thank you for the detailed presentation and how we love our graphs. So that's what I'm going to go back to, if you don't mind, page 13 or slide 13 in your presentation. And as I asked a little bit earlier today, the redetermination for eligibility, it's my understanding that we are required to do that in order to continue to receive those Medicaid dollars. And you have identified on your chart 498,000 folks that are just Medicaid eligible, with a crossover of an additional 406,000. So really, we're looking at 921,000 reauthorizations. What's the risk?
Robert Thompson, for the record, through the chair to the committee. There's very little risk, and let me explain why. So of those 921,000 recipients, those are not 921,000 redeterminations. Those are recipients. Families do 1 redetermination for the family. So you reduce your number there. Of the 921,000 recipients, we never lost contact with half of them. Half of them are on food stamps, and we're required in the food stamp program to conduct redeterminations every 6 months, and we never stopped doing those every 6 months. because they would have lost their benefit. So we never lost contact. We still have their income resources, and we know where they live. Of the remainder, we were very forward-thinking, whether by coincidence or design. We never stopped doing our monthly paperwork. We kept sending it out and saying, please cooperate with us, and half did. Approximately half. I shouldn't say half in a formal testimony, right? It was approximately half. So that leaves us with half of the half, right? So now we're down to 25% that we believe we are not 100% sure where they live. We're not 100% sure if we can find them. We're doing massive outreach through the Division of Healthcare Finance and Policy, our MCOs, to make sure that our customers know to update their addresses so we can get their paperwork to them. We have a year to work those cases, and we never stopped working those cases. The Welfare Division designed what we called a dynamic redetermination system several years ago, and that system pre-populates the application and sends it out, and these customers can apply online, and they can receive those notifications electronically if they opted in. So as long as we know where they live, if we don't know where they live and they don't do any of their paperwork, they're going to close automatically. The workload then there will be that they have to come back. So while we're having to touch all of these, and some of them we will have to touch twice, we are confident that we will meet that within the year.
And just one follow-up, if you don't mind. The deadline, I just want to be clear, the deadline for the redetermination is 1 year. When did that clock start?
Robert Thompson, for the record, through the chair to the committee. I'm going to ask Lisa to nod as long as I'm saying this right. The clock starts April of this year. Yes.
Thank you.
Thank you very much, and we'll go to Senator Harris.
Thank you, Madam Chair. So my question is also about the beautiful overlap chart, Venn diagram you have on 13. My question is about the folks who are only involved, let's say, in just one of these programs. So, for example, let's take the 498.5K or so who are only involved in Medicaid. How sure are we that that population is not eligible for SNAP or TANF?
Robert Thompson, for the record, through the chair to the committee, 100% sure that they're not eligible for SNAP, I could not give you. I can tell you that we do outreach, and when we do the interviews and we meet with these families, it is in our scripts to say, you appear to be under income for this program also. Could we connect you with it? But we also go further than that. The WIC is not under our division. WIC is under a separate division. And if somebody is eligible for food stamps and they meet the income criteria for food stamps and have a child 5 or younger under the home or is pregnant, they would be eligible for WIC, and we even connect there. So it's built into our scripts to do outreach. We call it in-reach. We have the outreach that we go out to, and then we have the in-reach internally, and make sure that we educate every customer that we talk to on the other programs that they may be eligible for. Sometimes it's a hard sell, and sometimes it's a hard sell with our elderly community, but we try.
And can I just ask a quick follow-up, Madam Chair? Am I living in a dream to think people could enter any one of these programs and just automatically be qualified for the other two? And, you know, there doesn't have to be a hard sell, or, I mean, it's like application, bing, bang, boom?
Robert Thompson, for the record, through the chair to the committee, yes. Each one of these programs is a separate federal program.
Honesty.
We work under the ACF, the TANF welfare rules. We work under the food stamp, the Food and Nutrition Services federal rules, and we work under the CMS federal rules. They've let us combine it all into one application. We've streamlined our eligibility to the best that we can, but we do not have the ability to auto-enroll. And I think that's what you're asking, is can you just auto-enroll? And we cannot. They have to ask us for the program.
I think the single application is probably pretty good, so thank you.
Thank you very much. And Senator Neal.
Thank you, Madam Chair. I had a question on page 15, the Energy Assistance Program. What's the actual caseload?
Robert Thompson, for the record, through the chair, to Senator Neal, I do not have the actual caseload with me at this time. We will have to get it back to you. I would be ballparking it, and I don't want to ballpark it formally.
Can I have a follow-up, Madam
Sure,
Chair?
please.
Okay, well, definitely get that to me because I'm super curious about that. But I also had a question on the Nomad program. So, according to my notes, it's going to be paid for with reserve reductions from ARPA. How long will it take? Because this was approved in 22, but how long will it take for you to get it up and running? And will those funds be enough to carry it to total completion?
Robert Thompson, for the record, Madam Chair, may I call on Deputy Administrator Swearengin?
For the record, Lisa Swearengin, Deputy Administrator for the Division of Welfare and Supportive Services. Through the chair to Senator Neal. We are going to, this program is actually, we're doing a contract amendment to an existing contract that we have. I believe this is scheduled for the March BOE. And we have already talked with the vendor, and they know that they have to have this completed by June 30th of 26, I believe.
And it's within the 20 million?
Correct.
Okay, thank you. Thank you, Madam Chair.
Thank you. Senator Titus.
Thank you, Madam Chair. And again, thank you for the presentation. I want to go back to page 8, where you mention your concern about the 14 days for the SNAP timeline to approve folks. And looking at it on that same page, you talked about targeted outreach, and you have 182 community partners. I've been out to the food bank in Northern Nevada and spoke out there and taken a tour of what they do. And again, food insecurity is a huge issue, and wondering if part of that outreach, when they apply, do you direct them to different food banks, so truly that pantry's not empty for 14 days? And then I have a follow-up to that.
Robert Thompson, for the record, through the chair, to Senator Titus. Yes, we do referrals constantly to our food banks. To clarify on the 182 community partner sites, those partner sites are partner sites that the welfare division sends case managers to. In addition to that, we have partner sites that we contract with throughout the community, such as the Food Bank of Northern Nevada, who are able to do our interviews for us. They are actually contracted and certified. They cannot approve the benefit, but they can do the interview. So we are, in the community, we are able to, and we encourage funneling those food insecure Nevadans to the food bank. So the food bank will do the application for us, start gathering the verifications we need, and then connect them with those services at the same time.
Great, thank you for that, because that's where I was going with my second question. Do you have anybody in your departments that actually are at the food bank or in conjunction with folks in the food banks that they may show up there first before they come to you? So if somebody might be hungry, they're running out of food, they'll go to the food bank first. And then do you have a way to capture them or a netting for them that then they can start that process to say, hey, there is a process where you could qualify, and so let's get this ball rolling. So do you have that already, that partnership already in place?
Robert Thompson, for the record, through the chair to Senator Titus, yes, we have, they're called trusted partners from the federal government. I don't like that term because it implies our other partners aren't trusted, but they're formally called trusted partners. We have contracts throughout, and those are at the food banks so that they can do that net right there.
So they're not part of then, if I might follow up, Madam Chair, they're not part of the vacancies that you have in your training. So that's in addition to you have these folks there to get that process rolling.
Robert Thompson, for the record, through the chair to Senator Titus, they are not welfare division employees. They are They are food bank employees, and then we pay them per application that they send back to us completed with the verifications. And they are allowed to do the interview, but they cannot, per federal rules, they cannot approve the benefit. So we have to scan the paperwork and do the actual eligibility, but they've already done the interview for us. So they connect them with both services at the same time.
Great. Does that cut down then on the wait to the 14 days by having those folks there, or is it still the average, or do you know?
Robert Thompson, for the record, through the chair to Senator Titus. It cuts down on the wait time as long as the food bank gets it to us quickly with the paperwork, because we have all the paperwork. We don't have to ask for anything.
Okay. All right. Thank you. Thank you, Madam Chair.
Thank you very much. Assemblywoman Gorlow.
Thank you, Chair, and thanks for being here. You guys have done an amazing job with everything that's been thrown at you. I just was kind of curious about the pandemic EBTs. How were those children identified? And also, is this still going on, or is it going to be running down or winding down?
I'll pass to Deputy Administrator Cantrell.
Kelly Cantrell, for the record, through you, Madam Chair, to Assemblywoman Gorlow. So they will be wrapping up. However, I don't remember the first part of your question. I'm sorry.
Sorry. I was just wondering how they were identified.
Oh, so we work in conjunction with the school districts and the Department of Agriculture, and they keep track of COVID-related absences, school closures, and so we get the information from them, and then that tells us who to reach out to. And in the beginning, it was any school that were closed for certain times, and then they've narrowed it down over the course of each school year to the number and the types of services that we can provide. And at this point, we're at a point where the last ones were COVID-related absences, only 5 consecutive days or more, and now it's going to be school-age, under school-age children only. So it kind of morphs as it's moved along.
Thank you very much.
Thank you very much. And I believe that Assemblywoman Kasama has a question.
Thank you, Chair. I'm looking at slide number 15 of the budget account summary. And again, I'm just curious under the budget item, child care assistance and development. For the fiscal year 2024, it shows federal funds of $166 million, which is reduced in 25 to $93 million. That just seems like such a shortage in supplying needed services. And I'm just wondering if you could speak to why am I seeing those large drops in the federal funds for the next year?
Robert Thompson, for the record, Chair. I will call on our agency manager, Carissa Loper, who is over the child care program.
Thank you, Robert. Carissa Loper, Agency Manager for Child Care for Division of Welfare and Supportive Services, for the record, through you, Madam Chair, to Assemblywoman Kasama. That is as a result of the loss of the ARPA dollars. So much of the additional ARPA funds that have been provided to the Child Care and Development Block Grant from the federal government will go away as of September 30th, 2024.
Got it. Thank you.
Thank you, Assemblywoman. And Assemblyman Miller.
Thank you, Chair. So I just have a couple of short questions here regarding page 8 and the vacancy rate. For my confirmation and clarity in my mind, your frontline workers must be licensed social workers as well, or no?
Robert Thompson, for the record, through the chair to Assemblyman Miller. No, that is not correct.
Okay.
Our caseworkers go through a college-style classroom that we provide. It's a training room, much like these rooms are. We do have a limited number of licensed social workers on our staff to deal with our customers who are in high crisis, such as substance use disorders or domestic violence, those high barrier. But out of the entire agency, that's about 40. So our frontline workers are customer service based. We train them in-house, and they are very accountant-like positions that are customer service based, that are trained how to do social services.
Okay, thank you. The so what's like the breakdown of from a number perspective, like how many, when you say there's 30% are less than 1 year, how many people is that when we look at where you are lacking?
Robert Thompson, for the record, through the chair to Assemblyman Miller. To get those specific numbers, I'm going to have to get them back to you. We have approximately, she's slipping me numbers, 1,251 case managers. But of those 1,251 case managers, when I talk about our frontline staff, 1,251 are not frontline staff. We have very specialized duties throughout the agency. We are required to conduct hearings. We are required to do testing of our systems. The outreach staff, if we allow our staff to go out into the community by themselves, that has to be the most veteran staff that we have. They don't have a supervisor or lead worker on hand. So when I was talking about our 20% vacancy rate plus 30% in training, I was talking about the ones that are specific to case management and answering our phones, and we can definitely get those exact numbers for you.
Okay, thank you. And then my last question, what's the biggest barrier to getting more folks in the door to filling the vacancies?
Robert Thompson, for the record, through the chair to Assemblyman Miller, we are struggling with the competitive pay.
Okay. Thank you. Thank you for the time, and thank you guys for doing a tremendous job with what you're working with right now. Thank you, Chair.
Thank you very much. Any additional questions from the committee at this time? Seeing none, thank you so much for all you're doing. And all the people that you are managing. And for those of you that are on the panel or the testimony today, thank you for preparing that. We appreciate your time. All right, with that, we are going to take a lunch break right now. So after lunch, we will do public and behavioral health, child and family services, aging and disability. I hope that fits within everybody's schedules, but there's at some point we need to break, and this is the optimal time. So thank you very much, and we'll see you at 12:30. Thank you. Boy, as a teacher, that's hard to do. So much easier just to say, welcome, class, to the afternoon session. Okay, I'll bring the subcommittee back to order. I hope you all had a good lunch. And the next item on our agenda is Division of Public and Behavioral Health. And Administrator Sherrick, if you will join us and begin when you're ready.
Good afternoon. For the record, Lisa Sherrick, Administrator for the Division of Public and Behavioral Health. Here with me today, to my right, is Cody Finney, Deputy over Regulatory and Planning and Behavioral Health Policy Programs. To my left, Debbie Reynolds, Deputy over Administrative Services, Joe Millay, Deputy over Clinical Services, and Julia Peak, Deputy over Community Health. Moving to slide 2, you'll see the division has been actively pursuing strategic planning and accreditation efforts this last year, and through that process, we have developed a new mission, vision, purpose, and mantra. I want to highlight that our new mission statement and our focus on protecting and promoting and improving the physical and behavioral health and safety of all people in Nevada. Specifically, our focus on equity is so all Nevadans can live their safest, longest, healthiest, and happiest lives. Moving to slide 3, highlights the core values of our division. Core values reflect the culture of our agency and our team. It is fundamental that our staff lives a life of service focused on health equity, partnership, innovation, integrity, accountability, and leadership. Moving to slide 4, this illustrates at a high level the organizational structure of our agency. Slide 5, and I apologize, it is kind of small, and we have many, many pages if you wanted the whole division. Slide 5 provides details of our 6 branches. As many of you know, DBPH is a complex division. We operate 4 psychiatric hospitals throughout the state and provide outpatient mental health services within 21 clinics in Nevada, as well as overall we administer over 50 programs across the division. Next slide. Though I cannot highlight every accomplishment of our team during the biennium, I do want to acknowledge that COVID has forever changed public health, behavioral health, and our agency throughout. I want to highlight the efforts of our team and the leadership in Churchill, Eureka, Pershing, and Mineral counties who are developing Nevada's first rural regional health district, otherwise known as the Central Nevada Health District. This will indefinitely change the landscape of public health in rural Nevada for the better. While much of the effort of our division may have never been seen by the public, I do want to thank the team for their robust response to COVID. And of note, Nevada had some of the lowest rates of COVID mortality among residents in skilled nursing facilities, and that was a concerted effort by so many people, not just luck. Last but not least, the division has received substantial ARPA funding to address public health, behavioral health, and forensic services in Nevada that otherwise would not have been possible. As for agency updates, we are actively seeking accreditation through the National Public Health Accreditation Board. Accreditation is a vehicle for transparency and trust in public health to ensure that we as an agency are providing foundational capabilities and meeting national standards for performance and quality. The division is also focused on modernizing our data systems and processes to run more efficiently and effectively. A key component of this effort is focused on data security, as the division houses some of the most sensitive data in state government. DBPH, as well as local public health departments, are working with Nevada's academic institutions to develop academic health departments to better connect public and behavioral health practice with academia and training. This not only supports workforce pipeline efforts, but allows growth in the area of research and public policy. Lastly, a major undertaking for the division is to implement a functional and comprehensive crisis response system in Nevada, sometimes referred to as 988. There are 3 parts to the system, which include a call line, mobile crisis, and crisis stabilization centers. Since our agency is so diverse, our priorities are as well. We highlight here some items that will be reflected in our biannual budget request, but also in our strategic planning, grant-funded programs, and daily operations. Specifically, we must address and improve our infrastructure for forensic mental health services. This is not only a mandate, but also a necessity to ensure the safety of our public. Improving the behavioral health, which is both mental health and substance use, will be a topic heard often during this session. Lastly, much of the public health priorities for the agency will focus on infrastructure improvement. Moving to slide 9. This represents DBPH's state fiscal year 24-25 biannual budget, and as you can see, it includes a 47% increase since the 2020-2021 legislatively approved budget. I also want to note the appearance of the reduction in federal funds is due to the large amount of ARPA funds that we've received from the Governor's Finance Office, which is counted as other and not considered federal since they are transferred to us from GFO and not received directly by the agency. Moving to caseload. Starting with our behavioral health caseloads on slide 10, you'll see our largest increase in caseload is medication clinic. I would also like to note that while the governor's recommended budget showed a decrease in outpatient services at Northern Nevada Adult Mental Health Services, we are now beginning to see an uptick in NAM's outpatient caseload. There will be another caseload update during session, which happens near the end of March, and we anticipate that's going to more correctly identify the increases that we're seeing now. Moving to the division's immunization caseload. While DBPH has never had an immunization caseload in the past and has historically budgeted the required general fund match for purchasing vaccines for Nevada Checkup, in order to ensure that Nevada citizens has access to vaccinations, we are requesting funding through caseload that can be used during each biannual budget cycle based on the Medicaid FMAP rate. Slide 11 is an overview of the division's facility populations. Similar to the outpatient clinics during the early period of COVID, our census decreased as emergency rooms and courts saw fewer individuals. A stay-at-home order may have played a role in these decreases. As mentioned in the caseload numbers, the number of services has increased over the past months in outpatient clinics. However, our inpatient hospital settings, the challenge is a little bit different. Nevada, along with many states in the U.S., are facing a competency crisis. Over the past decade, the increase in the number of court orders for competency restoration has been unprecedented. Specifically, the competency restoration is the process used when an individual charged with a crime is found by a court to be incompetent to stand trial, typically due to an active mental illness, and they must be restored to competency before the legal process can continue. This demand has challenged many states on how to add capacity to meet the need. One way to meet this demand and our judicial requirement is increasing the forensic bed capacity. Slide 12 outlines our 23-25 biennium budget account summary. Moving into our first major enhancement on slide 13. In order to meet the demand for forensic services, we have a number of enhancements focused on increased bed capacity and staffing. Of note, our forensic specialists are Category 3 peace officers required to go through a formal mental health certification process, which includes 10 mental health courses. Moving into our major public health enhancements on slide 14, first is the transfer of the account for family planning from the director's office to the division. DBPH has worked closely with the director's office to manage the account for family planning, which has been effective in supporting community partners and ensuring the fidelity of the program. However, moving the program fully to the division will allow the program to operate more efficiently. Next, DBPH is requesting a new account for public health infrastructure. This budget account will improve ARPA investments in the local health departments, as well as data modernization to the outdated public health systems. This includes a focus on quality improvement and transparency through public health accreditation and investments in public health workforce projects. Last, we are requesting to move long-term federally grant-funded positions to state FTE positions. These include these includes our maternal, child, and adolescent health and chronic disease and wellness programs. Slide 15 outlines our major regulatory enhancements, which includes 5 additional childcare licensing surveyors, as well as transferring the entire budget account to the Division of Welfare and Supportive Services to consolidate childcare-related programs, creating efficiency. This also includes 3 new management analyst positions to support our Vital Records program. In order, the additional staff is required to address the increasing workload. DPPH is also focused on coordinating urgent and emergency medical systems available to assist Nevadans. These include an information system for licensing and training of emergency personnel, a poison control hotline, and personnel to maintain and report on the trauma registry. By addressing these small but related issues, we can maintain and further strengthen the larger system of emergency assistance. Slide 16 outlines our major enhancements for behavioral health. In the 2021 session, SB 390 created the Crisis Services Fund based on a fee assessed on telecommunications and mandated the creation of a crisis response system. This requests the necessary personnel to support and manage the system. Slide 17 outlines several agency-level infrastructure requests necessary to maintain and protect critical operations with a focus on essential staff, support staff, and cybersecurity. Slide 18 outlines our overall division position summary, and 19 and 20 outline our requested BDRs. And with that, we are happy to allow a lot of time for as many questions as you're interested in asking.
Well, we'll find out if we need all that time. Senator Harris, please go ahead.
Thank you, Madam Chair. My question is about the establishment of the crisis response centers and the collection of fees from telecommunication agencies. Excuse me. If you could just give us a brief update on how that's going, that would be helpful. Thanks.
Thank you, Senator Harris. Through Chair to you, Cody Finney for the record. As you're well aware, that system was designed between this body and with a lot of help from Dr. Woodard in the last session, and the Bureau of Behavioral Health, Wellness, and Prevention has been working tirelessly on the implementation of the system that includes the 988 crisis line, which is live now, the development of the regulations and processes and infrastructure to collect those fees from the telecommunications companies. I will say briefly that being behavioral health folks, we had to learn a lot about the telecommunications industry very quickly. And we're continuing to do our best with that. So we are well on the way to getting those pieces in place to make sure that we can collect those funds. We have had some excellent communications with the industry and some feedback about what's needed to make sure that the intent of this body in the last session is in fact carried out. And we are in the process of working on those crisis stabilization centers as well across the state. Happy to answer any specific questions I may not have touched on.
Just one brief follow-up, Madam Chair. Thank you so much. Have we received commitment from the telecommunications agencies that they will collect and assess the fees that are sufficient to properly fund this process?
Thank you, Senator. Through the chair to you. The telecommunications companies have been very cooperative and providing us information and feedback and expressed to the staff their support for this program. They have expressed to us very recently that there may be some challenges with the definitions of a service line. And this is where is probably the extent of my expertise, that the definitions of a service line may affect our projections of what we can collect. And so we're working through that. But the industry has not expressed any resistance to us.
I stand ready to assist if needed. Thank you.
Thank you very much. Assemblywoman Brown-May, please.
Thank you, Madam Chair. Thank you for the great presentation. I just have a clarifying question about the 988 hotline. I see the behavioral health enhancement of 10 FTE, and currently we're trained to a national suicide prevention counselor. Do we have those positions staffed in Nevada currently, or are they staffed nationally?
Cody Finney, for the record, through the chair to the committee members. The question, if I might clarify, is are the people answering the phone at a national hotline or in Nevada? We do have an agreement with CSSNV, or Crisis Support Services of Nevada, and while calls can roll over to a national hotline, we do have that hotline in Nevada that is answering calls.
Thank you.
Thank you very much. Senator Nguyen, did you have a question?
I do, thank you. Just one question, I promise. There was a lot of money that came in federally through those ARPA funds and other dollars that were related to public health and the protection of those. Going forward with this next budget, like what types of cuts were cut or are not being, like, I guess, renewed now that we no longer have that money?
Julia Peak, for the record, I'll start on that one. So much of the funding that we received for public health varied from vaccination services to public health preparedness to epidemiology. Much of those funds have been given to us through a no-cost extension through June or July of 2024. So as long as funds remain, there will be support for those programs. We will be presenting also at IFC next week, as a spoiler alert. We did get a grant from the CDC that really is intended the best that Congress could do to support public health thereafter. And so it's more of a block grant looking at public health infrastructure and data modernization. DPBH will be getting approximately $9 million. Southern Nevada Health District will be getting over $20 million. It's population-based allocation. And so some of the services will be able to be continued through that. And it has a focus on health equity. So for example, Washoe County Health District is going to be retaining the staff working on health equity under that award. We also, graciously with your approval, have ARPA funds from our governor's finance office through the Treasury. Much of the projects we asked for in public health in that award is allocated through 2024, but as you are aware, we can spend through 2026. So many of those projects, we were thoughtful about that and have budgeted through 2026.
Thank you very much. Assemblywoman Anderson, did you have a question?
I did. Thank you, Chair. Thank you for the presentation. I actually have two questions, if I may. The first comes from slide 6, where you highlighted the successful partnering with local officials on the development of the rural regional health district. Is there an involvement of the tribal councils and or tribal leaderships with that development?
Julia Peak, for the record, I'll go ahead and take that one again. It's been a pleasure working with those counties. We have had conversations with many of the tribes in those regions. For example, some of the things we were looking at transitioning perhaps to the health district, one of which was WIC. One of the tribes is able to absorb another county in that. So we are going to continue to work with the tribes in that regard. We also have, through the grant I'm presenting at IFC next week, we've built in a cultural navigator, and the position is going to be solely dedicated to working with our tribes, because it's a challenge, and we need somebody that really is devoting their full time to that effort. And so they'll be working with the other health districts as we have tribes in the urban areas as well. So that position will be dedicated to supporting that regardless of the health district.
And if I may, Lisa Sherrick, also for that position, the key for us is making sure that they're actually going out personally working with the tribes and individuals, not behind a desk in an office making phone calls. We understand how important that is to develop those relationships, so that will be a requirement of the position.
Thank you. And then I do have a second question, if I may, Chair. And I'm not sure if it's in this presentation or the other one. It has to do with the caseload changes, in particular the closing of mental health hospitals, possibly in the north. I believe Assembly Member, one of my colleagues brought it up earlier, about the closing of a mental health hospital. How will that impact the individuals from the north who need help, in particular our youths, our individuals under the age of 21? That is one of my worlds, and I'm very concerned about their mental health as it continues to get harder and harder to get services in any area, but especially I feel like in the rural area, the northern area, in Vegas as well. So how will that impact our mental health help for our youth in particular?
Lisa Sherrick, for the record, through the chair to Assemblywoman Anderson. So DBPH, outside of outpatient services in rural Nevada, we only serve adults. So I believe that question is, for Division of DCFS. Childcare. I'm going to say financing and policy, but yes, DCFS.
No, but it does warm our hearts that you had to think about that.
Yes.
Okay, Senator Titus, please.
Thank you, Madam Chair, and thank you all for being at the table and doing what you do. It's not an easy lift, but we've all survived, and we're back for another round. You have already heard me ask this question, and it's going to be on 988. I've kind of been pushing questions on its implementation, and I know Senator Harris had asked a question about the phone companies or the communications companies. Are they going to be able to sustain it? But it's my understanding that there was a set rate based on service lines, and it's already been accepted that you already set the maximum rate per service line that was available per legislation. And I don't want to mimic my colleague to my right, but is that correct?
Cody Finney, for the record, to Senator Titus through the chair. Yes, that is correct.
Okay. So, and at one point, you had said you thought, based on the number of lines, that there might be as much as $15 million per, just calculating the math, per service lines. But today I'm hearing a little different, that there is some question about how much money that's going to be, because I think one of the push on that legislation was actually not just to establish this 988, but the wording was broad, and I think the wording said, and other mental health services, or something along that line, that we hope you could use that for some crisis intervention clinics or personnel, or so. I'm a little worried that, again, do you have any idea now what the actual budget would be, or you have to actually use? And along that same line, you were going to put out RFPs on services on that and companies, and it sounds like you've done that and you have some quotes on that, or where are we with that?
Thank you, Cody Finney, for the record. To Senator Titus through the chair. There was a lot to unpack there. So I will say that I see a lot of us, including myself, using 988 as shorthand for what we should probably really call the behavioral health crisis response system that includes multiple pieces and services. The 10 positions that we're talking about today are the smallest part of that funding. The bulk of the funding that we're talking about with this fee is for services and service providers. So where are we with that? We are, as we speak, working on a new projection to clarify this issue that really came up in the last few days about service lines, so that we'll have the best possible projection. And we will bring that to this body just as soon as we can and is appropriate through all the processes. The RFI is in draft form. We will be asking a request for information to make sure, and I think we've talked about before, that we have a solid budget and solid technical requirements for the system. There is an information system portion to this, a care traffic control system that makes sure all of these services can get to the people that need them. And we need that very specific technical information and budget information to do this right from the beginning and know how much it's going to cost and what we can afford. So that is in draft form and will be released very shortly, and then we will move to the RFP for that portion of the project.
Thank you. You answered that extremely well, and that's it. Thank you, Madam Chair.
Thank you. Any additional questions from the committee? Thank you very much for your time. It doesn't go past us that you give up your day to be over here with us and give us information, and your work continues. So thank you very much for being here. Okay, our next item on the agenda is the Division of Child and Family Services, and we have Dr. Cindy Pitlock, Administrator of the Division, and Dr. Pitlock, welcome, and when you are ready, please go ahead.
All right. Good afternoon, Madam Chair and members of the committee. My name is Cindy Pitlock, and I serve as the Administrator of the Division of Child and Family Services. And let's talk about kids. The Division of Child and Family Services is the main child-serving agency for the state of Nevada, with approximately, when fully staffed, 1,119 employees that work together to achieve our mission of safe, healthy, and thriving children in every Nevada community. We recognize that Nevada's families are our future, and they thrive when they live in safe and permanent settings. They experience sustainable emotional and physical well-being and receive the support they need necessary to make positive choices. The COVID pandemic was particularly hard on Nevada's families, further exacerbating a mental health crisis and lack of access to appropriate services. In Nevada, we recognize this emergency is overlaid on a system already insufficient to meet the basic mental health needs of youth and families. It is with these recognized insufficiencies, coupled with the DCFS mission statement, we are pleased to present our portion of the governor's recommends budget. I also heard some of the questions as the committee had brought them up, and I've interwoven hopefully some of these answers into my presentation, and we'll leave enough time at the end in case I didn't. With me today are Melanie Young, Deputy of Administrative and Support Services, Sharon Anderson, Deputy of Juvenile Justice Services, John Bradkey, over Child Welfare Services, and Dr. Jacqueline Wade, over Children's Mental Health Behavioral Services. So I brought you my entire team of ninjas. So the next slide represents our summary of agency operations and how we organize the oversight of our programs and direct services. I'd like to highlight some of our accomplishments, some broad sweeping challenges, and then we'll get into our enhancements specifically. There are a lot of accomplishments, but I'll try to narrow it down for the sake of time. We were very fortunate to receive a sizable investment of ARPA funding for services to address the children's mental health crisis. Many of you were involved in that through the interim and IFC, and I want to extend my thanks for helping us visualize all of that. We are working towards sustainability of those services, both by partnering with Medicaid and also in our proposed budget. This investment includes mobile crisis response, both in the communities and in Clark and Washoe school districts, intensive in-home family services, emergency and planned respite, both family and family youth peer support, peer-to-peer support, wraparound and intensive care coordination, workforce development, day treatment programs, as well as funding to replace the child welfare information system known as Unity. So very huge win for us. Moving on to another win, we've begun a pilot project of opening up female beds at Nevada Youth Training Center in Elko. Our goal is to shorten the time that females are waiting in detention and give them the ability to start those services faster. Until now, DCFS's only option for female placement was at Caliente. We've talked about how extremely difficult staffing is at the Caliente area and recruitment and retention, especially for females in the Caliente area to meet our ratios for needing those females to service a female population is extremely difficult. This gives us an additional option for females and the ability to be more nimble in our system between female and male beds depending on where the needs are. So that fluctuation and being able to be fluid for us is a huge win. Another win, Desert Willow Treatment Center is Nevada's only state-run locked psychiatric residential treatment facility for children. It has 32 licensed beds. That's 8 acute and 24 residential. As part of our goal of increasing to a total of 54 beds, which would be 12 acute and 42 residential, the division is utilizing approximately $6 million in ARPA funding to improve the facility, to reduce opportunities for youth to self-harm, and to improve security barriers for staff to reduce injuries. Specific improvements will include impact-resistant wall protection, safer ceilings and shower assemblies, new floors and walls, and protective barriers at unit nursing stations. This project is managed by State Public Works, and we're going to utilize a phased-in approach as construction is completed in various areas. Another win I'm very proud of, our infant and early childhood mental health program has succeeded in the creation of Nevada's first infant mental health association that will support the ability to become nationally endorsed in the specialty area of infant and early childhood mental health. Talk about going upstream, right? This program makes us one of the nation's leaders along with 34 other states. This will allow us to have a specialty endorsement, be able to participate in robust training and workforce development, create additional grant funding opportunities, and give us a rich training ground for our university students. This work has been in process for almost a decade, and we landed it. So kudos to my team. I'd like to do a shout out to Summit View. Our juvenile justice facility was recognized by the Nevada PBIS Technical Assistance Center, by the University of Nevada, Reno, and the Office of Safe and Respectful Learning with the Nevada Department of Education. They demonstrated excellence in leadership in the implementation of a multi-tiered system of youth supports called Positive Behavioral Intervention and Support, which is an evidence-based tiered framework supporting youth behaviorally, academically, socially, emotionally, and with their mental health. In 2021, the Nevada Department of Justice opened an investigation of our juvenile justice services within DCFS, which focused on the use of chemical restraints you would know as OC spray at the Nevada Youth Training Center and also at Summit View. The investigation has now been satisfactorily closed by the DOJ as we partnered to adopt new policies and practice that have significantly decreased the use of OC spray in those facilities. So very proud of my team. Relative to the opioid I can't even talk today, I'm sorry. The opioid epidemic, I heard that come up a number of times. I have directed the assurance that all of our youth parole officers and mobile crisis response team members carry Narcan. So the boots on the ground responders are ready to respond. So let's move in, if we could, to some agency challenges on a broad level. The United States Department of Justice released a final report titled Investigation of Nevada's Use of Institutions to Serve Children with Behavioral Health Disabilities. The report highlighted things we really already knew. Nevada does not provide adequate services in the least restrictive setting to youth with behavioral health disabilities. There is not adequate access to community-based services, and we over-rely on institutional settings. We also over-rely on emergency departments for screening, assessment, and stabilization of our youth with mental health issues. Those emergency department stays are often for extended periods of time. We are working across DHHS and with the Attorney General's office to develop a comprehensive response, and this is going to be an ongoing project. Another challenge, Nevada lacks adequate home and community-based services to help families receive support and stay united in the least restrictive setting. We know that the best place for youth and families are united in their homes and communities. These services are also vital to prevent unnecessary placement in a more restrictive setting, and conversely, for step down back into our communities and homes after an inpatient treatment. Another challenge we're focusing on, Nevada and particularly Las Vegas, is one of the most common destinations for traffickers to sell children for sex and for buyers to purchase them. The 80th session of the Nevada Legislature in 2019 saw the passage of AB 151 and SB 293, providing the framework for Nevada child welfare agencies to accept and ensure services for all commercially sexually exploited children, which we refer to as CSEC youth. These bills required the development of a plan to establish the infrastructure to provide treatment, housing, and specialized services. Basically, we can no longer funnel these youth through our criminal justice and detention systems. We need to focus on the decriminalization of our victims and provide them with specialized services, including reproductive health services, housing, mental health services, and reunification with family when we can. Another wide sweeping challenge we'll talk about a little bit more. We lack a number of sufficient foster homes, especially for youth with specialized needs. Both retention and recruitment have been problems statewide. You've heard a little of this, I'm sure, from everyone else, but I need to highlight my own areas as well as far as staffing shortages. This has really impacted our ability to provide direct clinical services and the ability to oversee the quality of our programs. For example, Caliente Youth Center has a 47% vacancy rate, which represents 49 people. Children's Mental Health North and South, direct clinical services, an approximately 40% vacancy rate, 180 people. Youth Parole, that protects our communities and keeps track of our youth, has a 23% vacancy rate, 12 officers that we don't have currently on the streets. And Nevada Youth Training Center has a 37% vacancy rate, which is about 35 people. Child Welfare and Administration are doing fairly well, with about a 20% vacancy rate. We have utilized and still continue to utilize every effort that we can to recruit, including flexible work schedules, utilizing contract staff when we can. The next slide shows our funding sources, with the majority of our funding being federal and general funds. Federal funds include Title IV-E that supports our child welfare services and victims of crime funding, and other funds include county assessments, whereby counties contribute to services offered in their county, and of course Medicaid billing and reimbursement for our direct clinical services. So when we get into our priorities, I'm going to highlight a problem and then an enhancement, and at the end, hopefully I've answered most of your questions. So the first problem, Nevada lacks a sufficient number of foster homes, especially for youth with specialized needs. Youth remain in inappropriate and non-therapeutic settings, such as Child Haven and Kids Cottage. These youth are often housed for extended periods of time in emergency rooms. The average number of youth on a wait list for specialized foster placement in Clark County is 40 to 45 per month, and specialized foster placement in Washoe County, about 25 per month on a waiting list. Yesterday's phone call told me that Clark County has 100 youth at the Child Haven facility, 10 of which poured in the door in a 23-hour period of time. Supporting our foster placements in the most appropriate, least restrictive, home-like setting is imperative for the physical and mental well-being of Nevada's youth. Our enhancement request, noting that the foster rate structure has not been evaluated or increased since 2008. DCFS engaged a contractor, Mercer, to conduct a rate study across all of our rate types. We found that due to over a decade of inflation, all rates are insufficient to meet the needs of foster families and to recruit and retain families. Temporarily, we were able to bridge this in the specialized foster rate by $20 a day, and this expires on June 30th. This immediate action was necessary because we were at risk of having providers not renew contracts at the end of the calendar year that we just had, causing a placement problem. The next enhancement for foster care decision unit is pursuant to SB 397 of the 2021 legislative session, providing stipend for foster youth from 18 to 21 years of age. This is so important to target our transitional age youth to set them up for greater success and increase their services and access to those services during that transition into adulthood. And if you really look at the cost savings that will have over the entire service array of all of the divisions, this is an extremely important initiative. Next problem, lack of sufficient amount of psychiatric residential treatment beds in both locked and unlocked settings. This level of care is imperative for step down from higher levels and to aid with smooth transition back into home and community and reduce emergency room waiting times. Currently, there are 73 youth placed out of state. This number is slightly up from 2019, where there were 58 youth placed out of state. Increasing access to Nevada's placements, coupled with a review of Medicaid reimbursement rates and the continuation of our build-out of our full system of care for children, will likely decrease the need for out-of-state placements. However, there are still some very specialized services, for example, the juvenile sex offender program or youth that are on the highest end of the autism spectrum, that those comprehensive services really aren't available in Nevada. We've also seen an increase in the acuity level of youth in our juvenile justice and mental health programs, sometimes requiring safe staffing levels to be 1-to-1 or 2-to-1. We've seen the increased number of juvenile justice youth that also need those mental health services. So we're really serving youth across programs. Enhancement request, reopening Desert Willow treatment bed capacity to fund a total of 54 licensed beds from the current of 32. Next problem, our mobile crisis response team has experienced a longer response team in the community due to increased number and acuity of calls and also staffing shortages. We've also seen increased need for response by qualified mental health professionals in our schools, which we're in the process of partnering with Clark and Washoe County for that school-based response. The enhancement request, together these decision units request the continuation of positions to continue that expansion into the schools and also into the community. Workforce development, this requests the continuation of ARPA-funded positions of a part-time public service intern program to continue our workforce development and pipeline into state employment. Problem identification next, as part of our continuation of build-out of our children's system of care. The next two enhancements seek to move, this one makes me smile and tear up a little bit. This is going upstream. This is early intervention that will help children not get pushed deeper into the mental health and child welfare system. This request, the first one, is the continuation of ARPA-funded positions to continue the day treatment center for ages 3 to 6 years old at the Northern Nevada Day Treatment Center. This is a new service line. It will accommodate 2 classrooms for additional 24 youth in a true dyadic parent-child service. The latency age day treatment program requests ARPA-funded positions to continue for the Southern Nevada Latency Age After-School Day Treatment Center, focusing on 7 to 11-year-olds, anticipated initially to serve 12 to 14 youth. So kudos to my team for going upstream. Outsourcing PRTF Enterprise, let me see if I can answer some of those questions with this response. So this decision unit requests the elimination of PRTF Enterprise in Reno, North Reno, as a state-run program. Due to our inability to staff with either contractors or state employees, we have initiated the request for proposal through our purchasing division and contracting process to outsource to a vendor that can fully open all 16 beds. Most of these positions are completely vacant, and rates of vacancies are so high across programs, we are not expecting any layoffs from this. Literally, about 6 weeks ago, over the weekend, we had absolutely no staff, as in 0 staff, to supervise and provide services to the 4 youth that were at PRTF Enterprise, and we had to relocate those youth to PRTF North in order to provide for their services and safety. We are not shuttering PRTF Enterprise at this time. We are using every effort we can through both contract staffing and state positions to open up even 1 bed if we can. So that is in process. Next, for the closing of unstaffed Caliente beds, we are recommending a reduction in the funding for staffing levels at Caliente Youth Center. We've talked about the staffing challenges there and our inability to meet our PREA ratios for female staff. PREA is the Prison Rape Elimination Act, which is a federal law supporting the prevention, detection, and response to sexual abuse and sexual harassment within the facilities. PREA requires minimum staff ratios to keep even staff safe and youth, both male and female. Our average census in fiscal year 21 for Caliente was 59. Fiscal year 22 was 46. So what we're requesting here is a reduction in unstaffed beds. These beds are empty. The overall impact on wait lists in detention that we have now is due to lack of staffing across all of our facilities, not lack of number of beds. Problem: over several biennium, Nevada has seen a reduction in vocational programs offered to youth in our juvenile justice facilities. Trade programs including hospitality, food services, welding, auto mechanics, and computer technology can give youth jobs with sustainable wage to support themselves. We know many times youth that enter into our juvenile justice programs lack credits in order to successfully graduate. This decision unit requests funding for an increase to the Clark County School District educational contract for Summit View. We contract with Clark County School District, and due to increasing expenditures, we've had to reduce the amount of educational programming. Currently, youth at Summit View receive 180 days of educational instruction, and this will allow for an additional 66 days to cover breaks in summer school. The next 2 enhancement requests are to provide an offset of court assessments and an increase of general fund appropriations to adequately support our victims of crime compensation, direct client support, and give us the ability to process claims faster and more efficiently, getting services to our victims. This fund is the federal funding source for victims of crime compensation. It is funded through court fines, fees, penalties, and restitution, which over the course of the pandemic, this revenue source dropped significantly. Next, Youth-driven expenses, these decision units are for facilities to comply with the letter of intent from the Senate Committee on Finance and the Assembly Committee on Ways and Means dated October 9th, 2021. The letter required the separation of youth-driven expenditures from traditional operating expenditures to ensure appropriate funding is budgeted. Administrative transfers, this seeks to create 2 new budget accounts to provide increased transparency and efficiency and to align with current administrative structure. The number of federal grants managed and the complexity would be much more transparent and manageable if we were able to separate those out. The next 4 slides show our data and expected rural child welfare caseloads, which are anticipated to remain relatively flat. The next 2 slides highlight our adoption caseload for both Washoe County and Clark County. The next slide highlights our facilities and our numbers served. The next, our budget account summary. And the next, our position summary. The 28 additional positions that you see with all the outs and ins by the time you get down to the 28 is really mostly the continuation of positions funded by ARPA that we've talked about for direct clinical services and realigning PRTF Enterprise to move those positions down to Desert Willow to strengthen that service array. And 2 are for the Victims of Crime program, and a few are just general realignment. Pleasure to serve youth and families. We're here to answer any questions you may have. Hopefully I answered a few of them along the way, and here for you. My team is here.
Thank you very much, and thank you for what you do. Senator Neal, did you have a question?
Yes, thank you, Madam Chair. So I had a question on the Clark County, it's the child welfare grant elimination. Is that under you?
I'm not aware of a Clark County Child Welfare Grant elimination. Perhaps we can get a little more information and get back to you.
Okay, so, yeah.
Absolutely.
All right, thanks.
Assemblywoman Anderson.
Thank you, and thank you for the presentation. You, as